So Nasser?
Ladies and gentlemen, it gives me great pleasure to welcome you in this series of webinars organized in collaboration with the World Federation of Neurosurgical Societies, the Mediterranean Association of Neurosurgical Surgeons, the MANS, and the Continental Association of African Neurosurgical Societies, the CANS. We started this 100 webinar project on 29th May 2020 with beginning of the COVID-19 pandemic. This was our first webinar. We already organized 64 webinars. Many of them were educational symposia with the WFNS. Today is webinar number 65. It is a collaboration between the Mediterranean Association of African Neurosurgical Societies demands and the International Academy of Neurosurgical Anatomy. And actually, I'm glad to work with Professor Imad Kanaan. I would like to thank him for such wonderful collaboration. Today's webinar is about pediatric tumors in neurosurgery. First of all, let me welcome all our distinguished speakers. I will go by the order by which they speak. Sergey Gorliev from Russia, Chandra Pujari from India, Anwar Ahmed from Abu Dhabi, Vladimir Binestri from Czech Republic, Ramesh Kirollos, Singapore, Thomas Santirias from Cambridge University in UK, Giuseppe Sinali from Italy, Albert Sofiano from Russia, Consiglio Di Rucco from Germany, Carmen Motolis from France, Girish Solanki from UK, Manas Panigrahi from India, Saad Dawood from Algeria, and finally, Mariano Sokolovsky from Argentina. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time. Sharing your knowledge and experience with neurosurgeons across the globe is well appreciated. I would like also to thank and welcome our distinguished moderators, Alvaro Cordoba from Uruguay, Marco Fontanella from Italy, and Konstantinos Fountas from Greece, who is going to be replaced by Anastasia Tsiou from Greece as well due to unexpected commitment. As you can see, we have a very interesting program, which is divided into 3 sessions addressing a very important topic, which is pediatric tumors in neurosurgery. This screenshot shows that until yesterday, we had 900 registrants over Zoom for this webinar. I would like to thank all our registrants and attendees for joining our webinar series. To all attendees, we are glad to get all questions and comments. It will be monitored by the moderators through the chat panel or the Q&A. This is the type of certificates we are offering. In order to receive the certificate, please participate in the webinar from the beginning to the end. Certificates will be sent only to attendees who attend for all the webinars. Our webinar series are organized either in collaboration with the WFNS Education and Training Committee or scientific committees of the WFNS, sometimes with neurosurgical societies, whether national, regional, or continental, sometimes with universities like University of Miami. The maximum capacity of each webinar is 500 registrants. However, in some webinars, the organizing committee extends the capacity and open registration again for a limited time. This was the table of the last 13 webinars, and we can see that the number of registrants are highest in the WFNS symposia. However, not all the registrants participate. For example, webinar 63, 828 registrants, participating only 388. Certificates were sent only to 143, those who participated from the beginning to the end of the webinar. Our webinar series usually available on the YouTube. However, doing live stream and uploading our webinars to YouTube is a decision which is sometimes taken by the organizing committee, but not for all our webinars. This is the QR code if you like to scan it. Again, this is the QR code of the Pan-Arab Journal of Neurosurgery. I'm glad to be the editor-in-chief of this journal. Submit your article, submission is free and publication is free. I'm glad to announce about our future webinars. Next Friday, webinar 66, which is going to be 17th February 2023 at our usual time, 2 p.m. Egypt time or 12 p.m. GMT, a collaboration with the Traumatology Committee of the WFNS. Glad to have collaboration with Professor Andrew Reisner, and an important topic also about pediatrics, which is Pediatric Neurotrauma Seminar with a galaxy of distinguished speakers. Webinar 67, it's going to be on Friday, which is going to be 24th February. another collaboration with the Spine Committee of the WFNS, Professor Salman Sharif, and important topic about acute low back pain and lumbar disc herniation. Webinar 68, it's going to take place on Friday, 3rd March 2023. We are almost working now every Friday at our usual time, 2 p.m. Egypt time or 12 p.m. GMT. Another WFNS Educational Symposia with Louis Borba, who is chairman of the Education and Training Committee of the World Federation. And it's going to be about intracranial meningiomas part 2. And webinar 69 will be organized on 17th March 2023, collaboration with Oscar Alves and the International Academy of Spine. Important topic about the craniovertebral junction anomalies with a galaxy of distinguished speakers from all the 5 continents. I'm also glad to announce about the Asian Congress of Neurosurgical Surgeons, which takes place in Egypt from 28 to 30 November 2024. I'm glad to be the president of this Congress and to work with Professor Yuko Kato, president of the ACNS. All of you are invited to participate in this important event. It will be a good opportunity to visit together the Grand Egyptian Museum. Thank you very much for attention. Now I give the mic to Professor Imad Kanaan to say his welcome note.
Hi, everybody. I think I greet all of you. I'm happy to be among you for this special webinar. I'd like to thank Professor Nasser El-Ghandour for his kind invitation, who embraced, and he, for me, is the catalyzer and the forerunner of international teaching and education, witnessed by the small introduction he has given what he's planning for the future. Okay. Not only for the past.
And tell them to send a picture because without that I cannot decide.
What is the sound?
For 1 hour in international seminar.
Moving sound and yeah. Well, I'd like to thank Professor El-Ghandour for his kind invitation. And our role, when he asked me what is the subject proposed, and I said pediatric neurosurgery. And this is something I felt that deserved to be on this webinar. And our role is to support the role of the International Society of Pediatric Neurosurgery, which most of us are supportive of this society. And especially in the past 3 decades, we have witnessed a lot of evolution in pediatric neurosurgery, including genomic landscaping of brain tumors, in specific introduction of novel treatments, and surgical strategy to improve our kids' surgical outcome for their brain tumors. And I think it deserves this webinar by the expert that I'd like to thank all the moderators and speakers of these sessions for the 3 sessions to be present and give their time and expertise and share it with us. I conclude in order to give a chance to start the webinar. I leave it to Dr. Nasser.
Thank you very much, Ahmed. Would you invite our first moderator?
Yeah, the first moderator is Professor Cordoba, and Professor Cordoba, Alvaro Cordoba. He is a known neurosurgeon for us. He has double heart, and we always like to mention that. I don't know whether he's happy to say he is the greatest classical musician on the guitar, and he has been performed several in our meetings, not only giving presentation on neurosurgical and advanced neurosurgical topics, but and the musical part, which is the first language we all know about it. He will be the moderator of the first sessions. And please, Professor Cordoba, you can go ahead and start this session.
Okay, thank you very much also for the invitation. It's a really honor to be the moderator here. I invite Professor Sergei Borelishev from Russia, a very interesting topic about brain tumors in infants and molecular genetics. You can start, Sergei.
Thank you so much for invitation for this outstanding webinar. Dear colleagues, dear participants, My speech is devoted to the molecular genetics of the children tumors, especially in the infant tumors. And we shall try to answer the question, does it influence the neurosurgical strategy? Brain tumors may be a part of numerous hereditary syndromes and genetic mutations. This is not the full list. The list may be very long, but we can remember some of the genetic pathology. We should keep in mind the possible appearance of brain tumors in some syndromes, and some of them are shown on this picture. Moreover, antenatal MRI gives the possibility to reveal brain tumors. This is the peculiarity of the infant brain tumors, so we can reveal them even before birth. I am far from the dream that a neurosurgeon may keep in mind the molecular genetic structure of a tumor while during his surgery. But nevertheless, we should know the answer to the question how molecular genetics may influence treatment tactics. It may permit to decrease radiation doses, to personalize chemotherapy, or to use target therapy. But how molecular genetics may influence surgery tactics? By no means. We don't know molecular genetics diagnosis before surgery. But nevertheless, it is possible in cases of previous biopsy and second look surgery. And so how molecular genetics may influence surgery tactics? Operate or not to operate? How radical should we be? And if on one hand, we have the radicality with high recurrence-free survival rates, and on the other hand, the possible deterioration of a neurological, endocrine, and cognitive functions. So perhaps the molecular genetics may judge this equilibrium. Let us see. So we shall start with medulloblastomas. So what do we have in surgery? So the extent of resection is currently identified as a high-risk marker. So the survival in cases of the gross total removal is much better than in cases of subtotal removal. But we have to keep in mind that gross total removal is possible only in 70% of patients. While the surgical manipulations near the brainstem, this is the main cause of neurological sequelae. In cases of brainstem invasion, gross total, near total removal is recommended. So this is a very important fact, especially in young children, that there are no significant differences in 5-year survival between gross total removal and near total removal with small remnants. So, and these thin layer on the brainstem does not influence the 5-year survival due to the chemo and radiotherapy. So what do we have now in molecular genetics? All of you know about 4 groups of medulloblastomas in children, and everybody could be happy if investigations would not reveal 16 other groups. So, and everything became much more difficult. So these groups are shown on this picture. And today, as we speak about the infant tumors, there are 2 groups in the SHH group, which are attributed to the infant tumors, to the very small age. This is the red square. So this is the SHH group, and we have to realize that in this group, there are a variety of cases. And if SHH gamma is clearly a very low risk group and could be spared for toxic effects of high dose chemotherapy, especially in very young children, then TP53 mutations are highly prognostic as a very high risk group So many hopes are pinned on the approaching era of the target therapy. And here we have to stress that SHH signaling pathway may be very important to use the target therapy such as vismodegib or erismodegib, but this is, I think, for the future studies. So the surgical conclusion of medulloblastoma, so the remnants of the tumor does not influence the prognosis. The prognosis for the remnants more than 1.5 square centimeters may depend on the molecular subgroup, but there is no significant data. The worst results are shown in group 3 with metastasis and CHH with TP53 mutation. So try to do your best at surgery. WNT and SHH gamma in infants are low-risk groups, and we may leave small parts near the brainstem in favor of preservation of neurological functions. Ependymoma. What do we have in surgery? So the key in ependymoma surgery is postoperative MRI scans, and when necessary, carrying out early second look resections. So, but what type of ependymoma is safe for removal? So I think that these two groups are very favorable for the primary and perhaps for the secondary removal. This type on the lateral surface of the brainstem is suspicious for an excellent removal. And at last, these two groups on the lateral surface of the brainstem and on the near the ventral part and near the basilar artery are contraindications for the total removal. Recurrent-free survival rates highly depends on radicality. This may be very good, but what is the actual neurological cost of radical surgery? Look at these figures. So in cases of a high rate of gross total removal on the left, we have an excellent revival. But if we look to the complications, we shall see that we have to pay a very high neurological price for it. So what do we have in molecular genetics? Again, there is several groups which are being preferably revealed in infants. And the same as medulloblastoma, we have the variety of the molecular genetics variants. And each of them differs in tumor location, in age distribution, in gender distribution, and the most important thing, in patient survival. So, for example, these two groups in the posterior fossa, one of them is group A, and the second one is group B, are very different from the neurosurgical point of view. I think all of you knows this, but it was revealed that they are quite different in the molecular genetic structure. So if we look to the long-term survival, we shall see that infant groups are the worst groups for survival. This is the two lower graphs. But the good news that just for these two groups, now we have the inhibitors, the target therapy, which can improve these results in infants. So the surgical conclusion on ependymoma, we can say that target therapy can greatly improve the results in the most non-curable group, posterior fossa A and CT rayla, where actually the survival can be achieved only at the expense of radical removal and corresponding neurological deficit. High-grade gliomas. High-grade gliomas are not so common in young children. And of course, you know all of them. These are the hemispheric high-grade gliomas, the deep-seated thalamic tumors, and DIPG, the worst, the darkest page in the pediatric neurosurgery. High-grade gliomas remain one of the very few incurable pediatric cancers. Current treatment protocols include maximum safe surgical resection, maintaining functional integrity, radiotherapy, and a variety of chemotherapy options. However, some ongoing molecular studies suggest that tumors from long-term survivals might not actually be high-grade gliomas. So look at this picture. On the left, there is a histology with high cellularity, nuclear TPA, and other signs of high grade. But if we perform the gene expression profiling, we shall see that it depicts the quite benign tumor. And this is due only to the young children. Mutations in the IDH1 gene are hallmark genetic lesions in adult high-grade gliomas, but they're exceedingly rare in children. Instead, in children, we have another 4 major methylation subgroups. This is the H3K27 mutation exclusively occurring in midline tumors, H3G34 mutation exclusively for the hemispheric gliomas, and the tyrosine kinase inhibitors. This is one of the cases where we can use the inhibitor targeting for the TRK activity. And you can see that after 13 cycles, we have an excellent results due to this treatment. So surgical conclusion of the high-grade gliomas is that it remains to be elucidated whether most long-term survivals of the childhood high-grade gliomas simply have a different molecular disease. The most important translational lesson learned from recent retrospective studies is the value of routine biopsy of all high-grade gliomas, including DIPG, the diagnosis of which has been typically based on radiological findings alone. In the future, inhibitors targeting TRK activity can become an alternative to chemotherapy or can be used in combination or complex treatment of high-grade gliomas, thus preventing excessive resection in functional brain areas. And the last group, which I will stop, this is the low-grade gliomas, which are very common in children. So, for example, this is the chiasmal gliomas. So, of course, we should perform the surgery for the G and nodular tumors on the brain. But on the other hand, the surgery is impossible for diffuse bilateral tumors, typically associated with neurofibromatosis type 1. Low-grade gliomas that arise in the cerebral hemispheres or the posterior fossa typically are not aggressive and are often cured via gross total resection. Low-grade in the hypothalamus and chiasma pose a greater clinical challenge because of disease and treatment-related morbidities. Chemotherapy is the main approach to treating young children with hypothalamic low-grade gliomas, and radiotherapy is reserved for those who experience treatment failure following chemotherapy. So this is one of our results of investigations in our institute. And you may see that chemotherapy alone is not very effective in the treatment of the chiasmal gliomas. Surgery alone as well. The surgery plus chemotherapy may be the best variant, but you may ask me that surgery plus radiotherapy shows the best results. But there are 2 very important exclusions: the young age and presence of neurofibromatosis type 1. So what do we have in molecular genetics? So the most frequent mutations are BRAF fusion and BRAF V600 mutations, and of course neurofibromatosis type 1. And in this group, as well as in other groups, now we have the possibilities of the target therapy, the BRAF inhibitors and MEK inhibitors, so which may improve the results of our both surgical treatment and routine treatment. So there is a big hope on the BRAF and MEK inhibitors, which can stop progression of the low-grade gliomas in the functional areas, such as visual pathways, thalamus, and brainstem. This will help a neurosurgeon to perform partial subtotal removal and thus to preserve these vital structures. Thank you. I think that molecular genetics will allow us to develop a highly differentiated approach to the treatment of brain tumors and will dramatically change not only the drug therapy of brain tumors, but will make surgery more safe and sparing. Thank you.
Thank you very much, sir. It's very interesting. We have enough time to discuss the final of the session. We move now for Professor Chandra De Pujari from India with recent changes in management of pediatric brain tumors. Welcome, dear Chandra.
Thanks, Alvaro. As you can see from the title of the talk, there are going to be some overlaps because I think recent management of brain tumors, one of the main reasons why many treatments are developing more specifically is the molecular biology itself. And if you look at the fact that brain tumors are the most common solid tumors in children, especially in very young age, and this seems to be true all through the world. We've had a separate study in multi-center study in India, which showed that the frequency and the occurrence of tumors was almost same, apart from certain tumors like craniopharyngioma, etc., which seem to be more common in our part of the world. So basic question everybody asks is how different are the pediatric and adult tumors? And I think the recent WHO classification has shown us very clearly that the genomics seems to be different. And today you do not find a word being used like glioblastoma in childhood tumors, and similarly several other terminologies have changed. So what is really new when we are considering surgery in pediatric brain tumors? The classification and molecular biology has made a great change, as Sergi had just shown us, and I'm going to have certain case examples to emphasize a few points there. Imaging, I think, has made a huge difference, especially now we have come to the era not only about measuring the eloquence in imaging, which is used for pre-surgical planning, but also there is also a possibility of molecular imaging, as we'll see as we go along. So these are the molecular subgroups of high are very, very peculiar to children. You have already seen the BRAF mutations and the MAPK pathways being altered in pediatric low-grade tumors. One of the most important papers which has come recently from the American Association of Neuroradiology is the white paper on Diagnostic Imaging Committee and the SPR Oncology Committee, which have come out with their recommendations as to what should be the imaging protocols in pediatric brain tumors, and the evolving role on translation of radiomics, which is actually the imaging equivalent of molecular markers, and radiogenomics in adult and pediatric neuro-oncology are being actually now looked at the level of the CT and MRI itself. And therefore, there has been an update for the radiologists, which have shown that you need to do certain sequences to diagnose the tumors. And then there are additional sequences which are required for radiogenomics and also for preoperative visualization or preoperative planning of the patients. The most common tumor, like pilocytic astrocytoma, we all know has a cystic tumor with enhancing mural nodule, which can be excised completely in a common location like cerebellar hemisphere, like this one. And once you find that the tumor has been completely excised, that is usually the end of treatment, and the 25-year survival has been shown to be extremely good in such patients. But BRAF mutation and BRAF fusion needs to be examined in some of these patients, and we'll come to see those examples a little later. This is another pilocytic astrocytoma, which could be completely excised. You try to do this through the vermis, and I think you can find a nice plane of cleavage in a pilocytic astrocytoma to remove the tumor completely. Occasionally, you get something like hemorrhage even in a pilocytic astrocytoma, but this does not determine the malignancy of the lesion. It still depends on the molecular biology. This is another patient with a thalamo-peduncular tumor. You're going to have another talk later on this, which patient came with hemiparesis and in a drowsy condition because of hydrocephalus. First, the hydrocephalus was drained, and then the patient was subjected to radical surgery, and a complete excision could be achieved. Hemiparesis took about 3 months to recover, but this child is now normally going to school after 6 years or so. Optochiasal glioma, you have already heard Dr. Sergi about this. Nodular tumors can be removed, like this one could be removed almost completely, as you can see on the postoperative MRI. We have kept a little bit of tumor because it was adherent to the other optic nerve as well. And this patient has been observed and has not progressed in the last 2 years. On the other hand, this 6-year-old girl, where the tumor was almost surrounding the carotid artery and a little bit of tumor had to be left behind. In this particular patient, the residual tumor was then treated as it was BRAF mutation positive. The patient was first given very focal radiotherapy, and then I think targeted therapy is being planned depending on the response to radiotherapy in this patient. In very young children, as you have just heard, it is the chemotherapy which is the first choice. So though the tumor remains the same, the treatment methods differ depending on how nodular the tumor is, how much of the optic apparatus is involved, and later on BRAF mutation. And of course, the status of neurofibromatosis makes it completely different. I have this patient who presented with bilateral visual problems, but they remained stable. And in fact, over a period of 1 year, the tumor has involuted, which happens in some of these cases. About the brainstem gliomas, you've just heard that, though the staging or the various classification for surgical consideration was made by Epstein almost 40 years ago. You know that a focal tumor can be completely excised, like this kind of a tumor, and this tumor was indeed excised. It certainly helps today to have a good tractography, which gives you an idea as to what is the best corridor to go through. And in this particular tumor, we could go take that corridor, go through the lateral recess, and we could, once we make sure that the cranial nerve nuclei are not getting affected, when we create a passage, and then we remove this tumor completely, as we could remove this tumor in this particular case. And this is the post-operative scan, and this patient has not required any further treatment. On the other hand, the DIPG, most of them are now H3K27 positive, and that is the diffuse intrinsic pontine glioma, where we are offering upfront radiotherapy. There has been a rethinking on this. Should we be doing biopsy for this? And I think if you have more than 3/4 of the brainstem involved, usually there is no argument. But if you have a tumor which is involving less than 50%, if you have poorly differentiated margins, and in such patients, it may be a good idea probably to take a biopsy. There are now studies that the MRI can probably tell us what are the typical and atypical pontine gliomas, and you can many a times decide on the basis of this which patient should have a biopsy. Like this patient, we decided to have a biopsy, while the earlier patient we sent upfront for radiotherapy, and this can be done now safely by navigational methods. And today, I think the most important thing, as Dr. Sergi was telling us earlier, can we know the molecular biology earlier? I think there is at least a study in brainstem gliomas that artificial intelligence, putting the clinical markers as well as the MRI markers, can probably give us a very accurate prediction of which tumor will be H3K27 positive and which one will not be. And this has been studied on various models, and artificial intelligence has certainly helped us to determine these, and probably we may not need biopsy in all these patients to decide. In ventricular lesions, I think one of the most important changes have been brought up by the use of endoscopy for CSF diversion, biopsy, and endoscopic assisted surgery to achieve complete excisions. Endoscopy biopsy, of course, is under vision. It allows you drainage of the cystic component of the tumor. It allows you relief of hydrocephalus by ETV, septostomy, foraminoplasty, etc. You can better assess the spread of the disease, allows devascularization of tumor by coagulation of the pedicle, and it can help you to achieve a complete excision in a better way. And it also helps us to assess the completeness of the excision. So this is a patient where we have a third tectal glioma, and here only you need to do a third ventriculostomy, and usually further surgery is not required in this kind of a patient. And today, I think for posterior third ventricular lesions, almost it has become a protocol that if you have a hydrocephalus, you would do a third ventriculostomy, send CSF for tumor markers or take a biopsy, and almost 2/3 of the patient go directly for radiotherapy, especially amongst the children. We've actually had similar experience, and we have shown a success rate of 86.97 for CSF diversion and biopsy accuracy rate of more than 85% in this kind of category. For larger tumors like this is a SEGA. Endoscopic assisted excision helps you considerably in removing these tumors completely. And we have recently published in the Indian Neurosurgical Journal our experience of about 280 cases where we have been able to use endoscopy for various benefits as I just described. Intraventricular craniopharyngioma can also be treated now almost completely with endoscopic methods, and especially with availability of endoscopic CUSA. And we have also written about this in one of our recent papers. While in suprasellular craniopharyngioma, I think a transsphenoidal plus endoscopic ventricular approach has given us very good results and is slowly becoming a treatment of choice. Here again, I think the molecular markers are going to play a big role, because we know that the adamantinomatous and the papillary variety have different markings. You can probably see that even on the radiomics, and it has been recently published that a non-invasive molecular diagnosis could also be possible with MRI-based radiomics approach, even in craniopharyngiomas. The molecular biology deciding about surgical treatment, Dr. Sergi just talked about, medulloblastomas, which were the first tumors where we understood this. And now we have a definite risk stratification, which he has beautifully described. So I'm not going to talk about it. But one of our papers from our local cancer hospital, the Tata Cancer Hospital, has shown that machine learning, and more importantly, I think putting some of the features as on the imaging, the nodularity and the infiltration can give you a very accurate prediction. So there is a radio genomics possible even in medulloblastomas with the new MRI sequences, and can probably tell us if we should go for radical excision or not in these patients. I think Sergi has already told you the rethinking in childhood ependymomas, and I think beyond RELA fusion, I think we are now talking about the YAP1 and YAP2 fusions, and the differentiation between the relatively benign and more malignant ependymomas. And it can also tell us about the prognosis in these patients according to their age and according to the ZFTA fusion and YAP fusion in these patients. For eloquent area tumors, I think the imaging has played a big role by giving us good idea about the functional MRI, and that allows us to maximize our resection by these various methods. And neuronavigation helps us during surgery to achieve this. As you can see from some of these pictures, these tumors can be safely excised even if it is in the motor or premotor area, and these patients can be treated satisfactorily without causing too much of neurological deficit. These slides have been loaned to me by our fellow Dr. Nicola from Dr. Chinali's team, and the augmented reality is now also coming into use for better planning of surgery, and you can actually carry out some of these surgeries more safely, and you can practice it beforehand for a particular patient. The Human Connectome project is also putting another dimension to all the supratentorial surgeries, and has also helped us in determining various algorithms as to which would be the best way to approach these tumors, and how to avoid the post-op cerebellar mutism is one of their cases, has been loaned to me by these people. And this only tells us that we are not only going to be restricted, but we are going to be guided in future how to perform more safe surgery and where we can avoid radicality to make sure that the safety prevails. And I hope the molecular targeted therapy helps us to achieve what our surgical constraints are to overcome that. Thank you very much.
Thank you very much, dear Chandra. We have enough time to discuss later. We move to the next session. Here, I will have enough time to. The next session is by Professor Anwar Ahmed, Challenges in Management of Pediatric Brain Tumors. Thank you so much, Professor. Can you hear me well?
Hello?
Hello?
Just a minute, please.
Unmute yourself, Professor Ahmed Anwar. Unmute yourself.
Okay. I've already unmuted myself.
Now we have. No, you are.
Can you hear me now?
Yes.
Yes, now yes, perfect.
What about the slides?
It's quite small. Must also enlarge the picture.
Go
So,
into presentation.
inside, going. I'm trying to share and.
No, we can see, but you must choose the big screen in the right corner, down right corner of the computer.
The slide, is that just 1 second. Where should I see? I can't. On the right side.
Right
On
side,
the right, basically,
yes.
there are 4 squares. The one
Yeah.
next to it, to the right of it, for presentation.
This is a big screen.
On the first square, there's I cannot. There's new share, pause, alternate, remote control. Sorry, it's not coming.
Well, if you
need to go to the
Can I,
slideshow and click on them. After animation, slideshow.
okay, perhaps we move a little bit for the next, and we try to solve this problem.
okay.
You can see now. You know.
You can see me? I cannot see my slide now.
No.
No, no.
Go down on the right side. There is the picture on the slide there. On the right side, go down.
He is seeing different things.
Yeah, I'm seeing different screen. I don't know why.
Well, try to solve it a little bit, and then we can continue with Vladimir Benes, and we return to you, okay?
Okay, I'll try to do it.
Okay, perfect. The next one, the speaker is Vladimir Benes from Czech Republic, thalamo-peduncular tumors. Thank you very much, Vladimir.
Good afternoon, colleagues and friends. So I guess I will step in due to the technical difficulties now. So can I start sharing the screen? No. No, I think Professor Ahmed needs to stop sharing his screen so we can go on.
Yes. Please, Professor.
Yeah, I have
Try to
already
stop
stopped.
Stop
Is
the
it-
share. Exactly.
Music
Try to
share.
stop the share screen.
Okay, I've did it.
Okay.
Thank you. Thank you so much.
Yes.
Okay, so hopefully can you hear me and see my screen at this moment?
Yes.
Yes. Okay, so this is a great pleasure to take part in this webinar, and I will talk about pediatric thalamopeduncular tumors. So as you all know, this article from Stephanie Puget was sort of a landmark article which defined these tumors. And as we know, they arise at the interface of thalamus and cerebropeduncle. They are rather rare, comprise less than 5% of pediatric tumors. However, they are very surgically challenging because they are surrounded by a lot of eloquent structures such as internal capsule, corticospinal tract, hypothalamus, and various neurovascular structures. The clinical presentation is usually with a hemiparesis.
Sorry, Vladimir. Put your first slide, the presentation. We are seeing the full presentation. You need to start scrolling along your slides one by one.
This way?
Click on this first slide.
Yeah.
Double
full
click
screen.
on the first slide.
Hold on. So is it working now?
No, choose the first and then the full screen.
Full screen. I don't really understand now. Doesn't work? No.
No.
None?
Have to have presentation mode.
Okay. Presentation. On začátku. How about now?
Not yet.
Not yet. Wow. Sorry about that. I'm not really sure what's wrong with it now. So, okay, let me try to start from the very beginning. No. Tak. Okay, I think I have it now. So it should be working at this moment, right?
Yes, perfect.
Perfect. Sorry about that.
Go to the first slide.
Okay, so I shall go. So this I already talk about that the anatomical background and clinical presentation, which usually presents this hemiparesis and raised intracranial pressure, as well as thalamic disturbances such as sensory and pain and other other symptomatology. If the thalamic tumors extend into the posterior fossa, cerebral symptomatology can be encountered as well. The treatment plan for these tumors is necessary to be addressed by a multidisciplinary approach because the oncologist will sometimes have their say due to recurrent or residual tumors. The aim of the treatment plan is taking maximal control of the tumor and minimize treatment-associated complications and toxicity. In this plan, surgery plays a crucial role because it provides definite histology, it provides material for molecular analysis and future treatment options. It addresses the expensive behavior of the tumors and hydrocephalus as well. And most of all, for all of us, it's fun, or it can be fun at times. Surgery should aim at radicality, however, not at the cost of permanent neurological deficits. So we believe that the strategy should be maximal safe resection, especially in low-grade gliomas, because these have very favorable natural history and the patients have excellent chance of long-term survival. There is no such thing as having too much information about these tumors, so feel free to perform DTI to know where the corticospinal tract or the visual pathway are dislocated. And I usually like to have T2 1 millimeter slices in all directions in order to see where the vessels and nerves are dislocated by the tumor. This is, in my view, the most important or most helpful MR examination. During the surgery, you should take advantage of whatever technology you have available. That includes CSF diversion, either by extraventricular drainage or by lumbar drainage. You should use gravity retraction, of course, image guidance, and what is absolutely necessary is intraoperative monitoring. That is a must when treating thalamic or thalamopeduncular tumors. You should dissect the arachnoid widely in order to take advantage of great brain relaxation and this distraction, and you should keep the dissection plane whenever it is possible. The obvious key is good approach selection. So I advise our younger colleagues to study this article by the Spetzler group, which divides thalamus into 6 distinct regions, and each region has its own approach according to where the tumor is located to the thalamic surface at its closest. However, it is better to use a familiar approach and suffer a little during the surgery than to use an unfamiliar one, which could be more suitable. And if you are not familiar with it, you may perform it badly and lose orientation during the surgery. So stick to what you know if possible. Another thing that you should consider when choosing your approach is extracerebral extension of the tumor. And otherwise, corticospinal tract displacement, where the posterior limb of the internal capsule is located, where the visual pathway is located, and approach the tumor along its long axis if possible, because this will minimize the necessity of brain retraction. And if there is no extracerebral extension, access the closest thalamic surface that is available. So let's have a look at some examples. This is a pilocytic astrocytoma. We just approached through pterional approach because it extended in the basal cisterns by the carotid and optic chiasm. Subtotal resection was performed. As you can see, some small residual tumors within the peduncle itself. Another case which I approached through the orbitozygomatic approach. This allowed for a very nice trajectory in the upward direction. We dissected the basal cisterns widely, including the optochiasmatic area, in order for the frontal lobe to fall away from the cranial base. The third nerve was dissected of the tumor, which we can already see over here. Further dissection of the third nerve. Most surprisingly, this patient did not suffer from third nerve palsy after surgery, which was to my great surprise, despite all the manipulation that was unavoidable during the surgery. The cervical fissure was split. Here we already have the PCA along the cerebral peduncle, was dissected away from the tumor, and then we continue the dissection along all the sides of the tumor. Now we move to the medial side along the third nerve again, then to the top of the tumor against the temporal lobe. I try to take the tumor, sort of pull it towards me and see where the posterior part is. Wide decompression by accusa is performed as well, and other structures such as the tentorium and PCA and the fourth nerve were identified towards the latter parts of the surgery. So I will stop here with the video and show the postoperative pictures where we were able to perform a gross total resection. The patient suffered a transient hemiparesis, and as I said, to our great surprise, no third nerve palsy at all. You should use the ventricle when accessing the thalamus, either transcortically or transcallosally. I prefer the transcortical approach. However, both routes are acceptable. You should identify choroid plexus and choroid fissure and the fornix, and also the internal cerebral vein. You can expand the approach by transecting the septal vein near the foramen of Monroe, then split the choroid fissure and dislocate the choroid plexus medially in order to protect the fornix. So you can easily identify most of these structures on the preoperative MR. We can see here the internal cerebral veins, the choroid plexus, and the choroid fissure. This was a high-grade glioma of the thalamus, which we resected completely. However, the patient is now undergoing oncological therapy, and she suffered transient hemiparesis, which later regretted ad integrum. This is another case which my former former boss did. He did a lot of epilepsy surgery, so he used a familiar route, which I probably will not be considering. However, he approached it as a sort of epilepsy surgery, which is also possible, so through the temporal lobe, and performed a subtotal resection. So, as I said earlier, whatever you are most familiar and most comfortable with should be approached. Natural corridors that are presenting itself, this is obvious case for supracerebral infratentorial approach, when you know that the corticospinal tracts are dislocated towards the front of the tumor, so you can safely approach this tumor from behind. As you can see, the 10th arachnoid bands are dissected at the superior pole of the tumor. Dissection proceeds towards the brainstem, and as you can see, other structures will come into view, like the posterior cerebral artery. The tumor is then shrinked and debulked, and dissection proceeds along its borders. Here we already see the brainstem, and pieces of the tumor are taken out from the ventricle, as we see here. And then the last part is taking out the tumor from the peduncle itself. So we performed a near total resection. There is a small residual over here, which I was unable to resect safely, and this has been kept under observation for 2 or 3 years already without any evidence of growth. You should also consider what is achievable under the current circumstances. This is a high-grade diffuse midline glioma. As you already heard earlier, the patient presented in deep coma and gradually improved, however, was almost hemiplegic. The aim of the surgery was to decompress the corticospinal tract, which is located anteriorly based on the DTI sequences. So we considered 2 approaches, through the ventricle or supracerebral infratentorial. I went for the trigonal approach because I believed that the CST could be decompressed more easily this way, which proved to be the right choice. However, we were unable to perform more radical resection due to intraoperative decrease of MEPs and proximity of the corticospinal tract. Knowing the histology, we opted to stop the surgery and either return in a second sitting or wait for the oncology guys to do their job. The hemiparesis very, very slowly regraded almost ad integrum as well. As we can see here, the improvement of the anatomical situation. So now I shall shortly present our series on low-grade gliomas, which were addressed with this surgical philosophy of maximal safe resection. It was a retrospective study. The endpoint was surgical morbidity, mortality, and oncological outcome. I already spoke about the surgical adjuncts. We treated 21 patients during 15 years. Typical symptomatology, and all the tumors were classified as low-grade gliomas. 6 patients were resected totally, 6 patients were resected near totally. In 9 patients, we were unable to perform a more radical resection. There was no mortality, and 6 patients showed signs of immediate neurological progression. However, all but 1 subsequently improved, so the permanent morbidity is not even 5%. And the median Lansky score at the last follow-up was 90, which is rather excellent. 5-year overall survival was 100%, and the 5-year progression-free survival was 64%. What we found that those patients who underwent gross total resection had no disease progression compared to those who had less extensive resection. So whenever possible, we should aim for gross total resection. So in conclusion, thalmopeduncular tumors can be resected with acceptable surgery-related morbidity and mortality. The extent of resection is acceptable given the anatomical situation. Postoperative quality of life is crucial when addressing these tumors, but only gross total resection offers the best chance for complete cure. For those who would be interested in our experience, I recommend this article in Acta Neurochirurgica. And with acknowledgement of my colleagues from Center for Pediatric Neuro-Oncology, I thank you for your attention.
Okay, thank you very much, Professor. We asked Professor Ahmed if it was possible to solve your problem. We continue, otherwise with continue with the final of the session and with the discussion. Professor Ahmed.
Unmute yourself, Professor Ahmed.
Yeah, can you hear me now?
Yes, perfect.
So can you share my now? Can you see my slides?
Yes, but you must to select one and then to put the full screen.
Yeah,
because
yeah.
otherwise we'll see the totality of the presentation.
You can see my presentation all or?
Yes, but all of it, all of the slides. You can choose one and then to put at the lower part at the right, full screen.
Yeah, I'm trying. Full screen option is not there.
Okay.
Just
Well,
one. I'll
I
try
think
one.
yes, only one because we have not enough time to have the discussion, and then perhaps at the final we should try to solve, because we have a lot of presentations and a lot of sessions, 3 sessions more.
This slide. Slideshow is it coming now? Slideshow.
No, and unfortunately not.
This is it. It's not coming. I'm sorry for the technical glitch.
No problem. It's a really pity, Professor, but we must to continue because we have not enough time to. Otherwise.
Sorry, can I just say, Ahmed, just click from beginning. Do you see that the first icon from beginning, where you are right now? Click from beginning, above that slide. From beginning. Above it. That's
okay. Yeah. Okay. Is it now ready? Can you see it?
It will start.
Yeah, I can see on my screen.
Now you need to select it. When you share, you need to select that screen to share. Because at the moment you are sharing that screen. Now go back to the screen share and select the show. Yeah. Then now select the show. The
show is where, Guresh, I can see the screen and.
Dr. Nasser.
Click on resume slideshow. Click on resume slide. That's it.
Hello? Yeah, where did you go? You left me alone. But sorry, no problem.
Can I do it like, can you see my first slide, challenges in pediatric brain tumor or not?
I have a problem with that.
No, unfortunately not. No, it's not in a full screen presentation.
Okay, sorry, I don't want to waste time.
Okay, well, we continue with the discussion. It's a very nice topic, a lot of presentations in a very, very nice manner, and it's a very interesting field, mainly for the future of the surgery and the treatment of the brain tumor. I remember very well here, not in a child, but in an adult, also was a very well-known surgeon from Uruguay. We operate twice for a high-grade glioma, and actually survived more than 88 years after the second surgery. So I think it's very interesting to know what happened in this area with all of the target treatments, mainly in immunotherapy, and we must to understand what happened with the behavior of the tumors in the basis of the molecular behaviors. So mainly also in childs, it's very interesting to explore, and I think it's a very huge field to mainly for the young generations of the neuropediatric and pediatric neurosurgeons. So it's very interesting, but I think it's not available in all of the countries actually, because I think the kits for the reactives for a lot of investigation, they are very expensive for us. Otherwise, I think in the future we try to make much more wide the field of this kind of approaches of the tumors. In the other aspect, I think is actually we are not convinced this is total 1 year total resection is really perhaps the best way to approach this kind of tumors, because in some tumors we have no difference of the survival. So I don't know which is the experience of all of the colleagues that spoke in this session, but I am very enthusiastic, perhaps in the future, mainly for the young generations. Well,
I'm sorry, I am trying my best to get the screen share, and it's on my computer,
yes,
but it's
we,
not.
we understand. We understand, Professor. Don't worry about that. Sometimes happen, and that's happened to me several times, and I understand you very well.
I can see the slide on my whole screen, and when I try to share, I just go into somewhere lost. I can't see my slide.
You can send your presentation to one of us, and then we can play from our.
Yeah, perhaps at the final is possible. Okay.
Okay. So thank you for allowing me this opportunity. I will just say verbally a few words. We are talking about pediatric brain tumors, and my topic. Can you hear me? Yes.
Yes, for sure. Yeah, perfect.
Yeah. The thing which is important as a pediatric neurosurgeon is that we have to see the patient with a brain tumor in three perspectives. One is what is the tumor they have, and the second is what age group they have, and the third is how it has affected. All these, my previous speakers are excellent surgeons. They have shown their classical work, but the lack in our neurosurgery is that we don't have the perspective of what the parents want for their child. They want the best care from us to make them happy and free disease. And this has to be taken as a challenge that we divide pediatric neurosurgery tumor problem in three major age group. One is under 3 years. The second is 3 to 9 years, and the 9 to 18 years. They all have a different dynamic of physiology, pathology, understanding their disease, because a child who is school going is different from a neonate or an infant who had a posterior fossa tumor. How much we involve that child in the tumor surgery, how much we explain the complaints, because this part of the challenges are we missed in practicing in the low income and in UAE. And this is an important message I want to convey to my future pediatric neurosurgeon. There are three perspectives, how you deal with this. You have a child who has a brain tumor is with the GP or in community. How you deal with that with the 3 P's of pediatric neurosurgery.
Professor Anwar, sorry to interrupt you. These are very valid points. You are going to be invited next time. There is always a second time. You are not the first to cut your presentation.
Yeah, I feel bad.
You will be invited again, but I think we should proceed, and I let Dr. Alvaro continue with the discussion. Otherwise, you will lose part of this, and you are not presenting your presentation. So I think keep the things for the future.
I have to give some message. That's okay. Thank you very much.
Yeah, the message is taken. Thank you.
Yeah, I spoke about that. There's very, very interesting things, and mainly, I think it's a very, very, very enthusiastic future. We have a very enthusiastic future in tumors. I think not only perhaps in the gross total resection, or not, or the supramaximal resection, like this is actually is very important to know. But I think we have a very, very wide field to explore in the future for the next generations of neurosurgeons. And I actually, at least for me, in my experience, I very am curious about what happened with this kind of tumors in children, also in adults, that are completely out of the expectations of the survivor. Perhaps this is, we have a lot of different kind of cancer stem cells, perhaps. And at least in my opinion, I try to use in very useful manner the confocal endoscopy combined with a lot of new strategies of approaches of the brain tumors. Well, if another person have another comments, we close this session and we move to the next one.
Okay, I think we will move to the next sessions. Is it chaired by, who is the one, Professor Anesthesia or Professor Markov Fontanelli. No, I think Professor Anesthesia is taking care of the second session as a moderator.
Yes, hi.
No,
Hi.
no. Hi, Anesthesia. I think Marco Fontanella now. Anesthesia will be third session. Marco, are you here?
Marco.
Okay, so we move to this session. I'm impressed about the huge experience of all the speakers. You are really very great neurosurgeons around the world dealing with these tumors. And the next speakers will be Rames Kyrillos. I think you all know Rames Kyrillos, that I think he was graduating in Egypt. Correct me, please, Rames. And but we all know that we were for a very long time in UK, and it was a brilliant vascular. I know because he's a very good vascular surgeon also, and Rames, and we are happy to learn something about your speech. Please, Rames.
Thank you very much. It's a brief talk on anatomical consideration for surgical approaches for in the third ventricle, and I'm very grateful to the late Professor Roten, who I'm using his anatomical slides. The common intraventricular tumor, of course, by far in the third ventricle, by far in the adult sarcoidoid cysts, they do appear in pediatrics, but not as common. Of course, I'm talking about predominant intraventricular tumor, not coming from the parenchyma and extending to the ventricle. You can get pure pilocytic predominant astrocytoma, and also colloid plexus tumors are more common in the lateral ventricle. They appear in the third ventricle, but also craniopharyngioma and pineal tumors can present a large portion of them into the third ventricle. And the experience now is more than almost 130 cases, but mainly you could see that even I have 75% or 70% of my pineal gland tumors were extending a lot into the ventricle, and almost 50% of the craniopharyngioma as such. And when we decide an approach in the order, first we have to see if there is an indication at all for resection. These cases have endoscopic biopsy and go for adjuvant treatment. And then first, before we decide the corridor, we have to predict what is the extent of the resection and tailor it according to the location, the biology, the blind spot, and then choose the appropriate simpler approach because there is a morbidity of the approach. So the anatomy of the third ventricle in the floor, a lot of it is over. You can see the tectum and tegmentum of the midbrain, and extend anteriorly. You can see the mammillary body and the tuber cinereum. Anteriorly, it has the lamina terminalis here, which is attached to the rostrum of the corpus callosum, with the anterior commissure here and the column of the fornix, extending to the suprasellar cisterns, and again posteriorly to the pineal and quadrigeminal cisterns. And on the top, it has the connection to the lateral ventricle through the choroid fissure, and we have here the fornix. Here is the more detailed anatomical picture with the mammillary body and the suprachiasmatic recess and the infundibulum, with again the anterior commissure and the column of the fornix, with the posterior commissure and the pineal. So the entrance to the third ventricle is either from the lateral ventricle or anteriorly part, either through the lamina terminalis, or if allows by the lesions through the floor of the third ventricle. And also for lesions from behind, you can go through the quadrigeminal cisterna and pineal region into the posterior third ventricle. But what in the third ventricle is important, because we have here, as you can see, the hypothalamus in the floor, and the anterior part separated by the hypothalamic sulcus, and we can see here the habenula with the anterior nucleus of the thalamus, with the striatum medullaris thalami, the column of the fornix, anterior commissure, and this is the tract of mammillothalamic tract being divided. So you have a lot of structure in there. The important vascular structures are the perforators from the anterior cerebral, from the basilar tip, and the choroidal vessels, but also more relevant to surgery are the venous system with the septal vein, internal cerebral vein going to the vein of Galen posteriorly, which are potential area of morbidity. With the roof of the third ventricle, these are the fornices reflected. You have the internal cerebral vein in the velum interpositum with the branches of the posterior medial choroidal artery. So this is the roof of the third ventricle. So again, these are the approaches, as I said, and I divided the approaches of lesions in the third ventricular body itself. And I will show you the approaches, the blind spots, the structures potentially could have morbidity from the approach and from the resection. And then we have the posterior and anterior parts of as such. So if we start with the body of the third ventricle, we go mainly through the either foramen of Monro or the transchoroidal approach. So we have to reach the third ventricle first, either through a transcallosal or a transcortical approach, and then decide whether we go through the foramen of Monro or through an transchoroidal approach. So this is the classic transcallosal approach, which I'm sure you all know. Once we enter here, then we have to identify the foramen of Monro and the rest of the choroid fissure and decide. So when we enter the lateral ventricle, the first approach is through the foramen of Monro, but there is some morbidity of the approach and the resection. So when we enter the foramen of Monro, there is some anatomical consideration because any fornicial manipulations here will have a problem with post-memory dysfunction. So if we look at the anatomy of the foramen of Monro, this is an important paper we did from Cambridge to look at 100 normal subjects. It's an MRI anatomical studies to characterize the trajectories and the dimensions of the foramen of Monro. It's a difficult study because we have to get the correct radiological trajectory and estimate the, as you can see, get the trajectory and get the imaging, not in the coronal plane, but in an anatomical plane. So you can see here in anatomical plane, this is the true dimensions of the narrowest part of the foramen of Monro, which is really an intraventricular canaliculus rather than this approach. And what we find that in normal subjects, the foramen Monro is quite narrow. This is very different than cadaveric dimensions. So if we go through the foramen of Monro, we have to avoid morbidity by only choosing to go this approach from a widened foramen of Monro, which may not be always dilated when you have ventriculomegaly. So you have to look in the images properly. And also, of course, it's suitable for lesions extending from the third ventricle through the foramen of Monro. You just follow it and depends on the soft consistency, but be aware the blind spot will be the roof of the third ventricle. But for lesions like that, this is a meningioma and NF2 patient. Of course, the foramen of Monro is quite narrow, so you consider to go through the transchoroidal approach, which again has the same blind spots and morbidity from approach and resection. And this is the concept of the choroid fissure, which is around the thalamus, and outside you have the hippocampus and fornix. This starts in the temporal horn, and the most dilated part anterior is really the foramen of Monro. And when we do a transchoroidal approach, the callosotomy, as you can see here, is anterior. You don't go posterior callosotomy. You avoid the splenium, which can cause the visual discorrection, and also away from the fornix. In fact, this trajectory can expose you the whole third ventricle. So I don't perform posterior callosotomies. And then you have to really decide, because what is the limit is your thalamus striate vein. Sometimes you can widen the foramen of Monro if you have a suitable venous angle that the thalamus striate is joining the more posterior, the internal cerebral veins. And you can also divide the septal vein, but do not breach the thalamus striate vein. Then we open, this is the fornix, this is the tinea fornicis, and you open the choroid fissure subfornicial, and then you will enter into the third ventricle, just below the internal cerebral vein. There are exceptional cases. I don't choose the interfornicial approach unless of course, the lesion has splayed the fornices apart and make it more favorable to go interfornicial, but it is exceptional for me rather than transchoroidal. The other thing that extension into the third ventricle is either anterior from the suprasellar systems or posterior. If you go first suprasellar, this most commonly like craniopharyngiomas that has predominant intraventricular extension. And we can either enter the third ventricle through the lamina terminalis, which requires a transcranial approach, or an endonasal endoscopic transsphenoidal approach through the floor of the third ventricle. But again, the blind spots is different. You can see the roof very well through the endoscopic approach, but not through the lamina terminalis. And again, there are other considerations. So I'm talking about really not craniopharyngiomas because there are other talks. This is the significant third ventricular extension. So what we do for these lesions, first consideration, we have to see if there is strong factors dictating transcranial approach. Of course, we'll go transcranial and translamina terminalis. If not, then we have the choice between either doing endoscopic endonasal or transcranial. But what determines our choices is that we have to know what we are going to do with the extension outside. Is it suprasellar you need to address or not? And most important, the integrity of the ventricular wall, which has the hypothalamus that we should really don't disturb. And if it is intact, there is no role at all for the endoscopic approach because you cannot go through an intact lamina terminal floor of the third ventricle. These are the usual consideration that it's all in the textbook. But if you go in pediatrics in particular, the consideration we cannot use the endoscopic if the sphenoid sinus is not well aerated, although with image guidance you can overcome it. But we have to preserve the pituitary function as possible, and we heard the tumor biology is different. So the pattern of the ventricular extension is really depends on the integrity of the floor of the third ventricle, whether the tumor has opened the floor or not. And also with the endoscopic, you have the, it is very difficult to deal with the solid part in the interpeduncular systems, which is the blind spot for the perforators, without disturbing the stroke, which defeats the purpose of preserving the pituitary function. And in pediatrics, a lot of them are calcified, and you can have vascular injury with the endoscopic rather than transcranial. This is how the perforators are related to the floor from the basilar. And other factors, of course, adults or pediatrics, whether the tumor is above or below the optic chiasma or involving multiple compartments. This is how the good case for endoscopic endonasal approach, which you can see, you look straight into the roof of the third ventricle and you have good resection. And as such, you can see that endoscopically through the hypothalamus at the end of the procedure. For the transcranial approach to the lamina terminalis as such, for a lesion that is really going more lateral on the carotid, which is not suitable for endoscopic anyway. So the third ventricular extension, which happens to be cystic, can be delivered through the lamina terminalis. And this is the images, anatomical images. I just have to say that open the lamina terminalis anterior to the anterior communicating artery, because posterior you have the hypothalamic perforators. So if you mobilize the ACOM, do it anterior to it. And this is an example that has such a procedure. Of course, there is a role for transcallosal approach if you have a pure third ventricular lesions. And in fact, for this, if it is cystic, you can just do an endoscopic fenestration if needed, if it is really cystic. And again, has the same consideration that you use a dilated foramen von Roh, but it depends if there is, you have to address a large suprasellar extension going the whole way down to here may not be appropriate. Now, pineal regions can extend into the posterior part of the third ventricle as such, and I said many have done that in my cases. They extend through the posterior part of the third ventricle, and these are the two classic approaches, either supracerebellar or occipital transtentorial approach. But these are your considerations regarding how to choose. So it is better for a caudal extension in the tectum to use the occipital transtentorial, which avoid morbidity. However, when you have a lot of intraventricular extension from the lesion, then you use one of the other approaches. And you can see in a lot of my cases, only 9 pediatric cases required resection because a lot of them have endoscopic biopsy, they are germ cell tumors and have adjuvant treatment. So these are the different approaches, but in fact, this is the occipital transtentorial approach. Is great for lesions going down in the tectum. However, around the corner from the prominent splenium, it is very difficult to see the intraventricular extension superiorly. And hence, it is better to use the intratentorial supracerebellar approach for an extensive intraventricular lesion as such. This is the approach here, inferior, posterior. This is the initial part of the dissection. And then we have to go and look at the roof of the third ventricle because it will be adherent to the internal cerebral veins. And you can see how brilliant the view from below. You can see the internal cerebral vein. This is the Vermian vein before it was divided. So this is the roof of the third ventricle, and excellent view, the supracerebellar approach, which is used for the ones that have significant intraventricular extension, and you can see a good resection at the end. However, how aggressive we should be with the tumor, we have adjuvant treatment, so we have to be careful because a lot of the morbidity is really related to the tectum, and unfortunately, these are quite complex. It's not just upward gaze. This is again to show how important it is to the quality of life. It is very difficult to correct this minor changes. You may not detect it, but have a lot of functional problems to the patient because of this complex arrangement in the tectal plate, and that's what we call parinode plus with any damage to this part if you are more aggressive with the tumor. And with the supracerebellar approach, this is the relatively blind spot for you. It is the better address with the occipital transtentorial, but it's a problem, as I said, when you have a large intraventricular extension. So finally, we have to be careful how to rationalize our approach. Something like that is not good for an occipital transtentorial for this part. This is not good for a supracerebellar, and perhaps for such a lesion, mainly maybe a transchoroidal approach would be more appropriate. So you have to think about it. All the anatomical consideration I mentioned applies to the endoscopic and endoscopy-assisted procedure. These anatomical principles, either going through the foramen of Monroe, its dimensions, its trajectory, anatomy is very important for that consideration. And this is finally how I put all this table together. So the choice of approach has to be tailored. You have to be aware of where is your blind spots. And don't forget, it's not only there is a morbidity of resection, there is the added morbidity of the approach. And thank you very much for that. Thank you.
Thank you, Ramesh. I think a very good lesson about how to reach this region. Now we can listen to Thomas Santarius. Thomas Santarius works in UK, in Cambridge, I think, and about the tumors of the third ventricle, the disease of the third ventricle. Please, Thomas.
So hopefully I'm sharing a screen with you now. Can you see my slides?
Yes, perfectly.
And clearly you can hear me. So thank you very much for your kind introduction. Surgery and particularly anatomical aspects of it are repetition. You know, Ramesh has already pre-digested lots of stuff I'll be talking about. I thought I'll share with you the picture from one of the old books, medieval books, that is here in the library in Cambridge, and particularly I'd like to point towards this worm that controls the flow of the spirit between the ventricles in other words, the pineal gland, it's clearly been captured imagination of physicians over the centuries, and has been even considered to be the seat of the soul. So again, I'd like to acknowledge the contribution of Dr. Rothen and many of his fellows, and lots of other anatomists who have taught us a lot how to operate, and this is essential anywhere in surgery, anywhere in neurosurgery, and not least in operating and pineal surgery. But this is not the only consideration. As Ramesh said, we need to know whether we need to operate and precisely what the objective of the surgery, and this is very important in pineal surgery, and particularly in pineal surgery in pediatrics. And this is primarily because of the first column here of germ cell tumors, which most of them require non-surgical treatment. And surgery, the contribution of surgery in this tumor is, of course, in some cases a complete resection, like in teratoma, but sometimes biopsy, and sometimes no surgery is required whatsoever. And we don't have really time to go through the details over it, but I'd like to highlight the fact that it is really a complex issue. It partially depends on what state the patient is presenting to us. Many cases will present with a hydrocephalus, but some of them with very acute hydrocephalus, where pretty much we need to do CT and go straight away for some sort of CSF diversion, which can be, if in a very urgent case, just an EVD. If we have more time, we aim to do an ETV, and while we are there, if it's favorable, we can take a biopsy, but we should definitely take CSF for cytology and CSF markers. And of course, we can at any time take serum markers. So if what I mean by marker is beta HCG and AFP, and if any of these are significantly positive, we are dealing with a tumor that should undergo oncological treatment primarily once, of course, we have solved the hydrocephalus issue. Of course, there are other tumors, and particularly the older the patients are, the spectrum of the tumors changes. So there are situations like this when we have bifocal enhancing tumor of this sort, fairly uniformly brightly enhancing. This can be taken as a diagnosis of a germinoma, and as you know, germinoma is not a surgical tumor. Just to show you, the very complex protocols for treatment of various germ cell tumors, and really these tumors from as early as possible need to be treated in the context of a multidisciplinary group, which definitely should involve oncologists, radiologists, etc. And this is really kind of the summary of the treatment of germ cell tumors within CSF, and the role of radiotherapy and chemotherapy. And essentially, radiotherapy should be administered in all cases of germinoma and malignant non-germinomatous germ cell tumor. And chemotherapy used as in the treatment of both germinoma and all cases of non-germinomatous germ cell tumor. But of course, we like, as most people, chopping wood, and therefore we would like to perform surgery as soon as possible. And this sometimes what happens. There was a case we had of a 19-year-old who came with sort of headaches and balance issues and maybe some occasional visual problems. And we thought it would be a germinoma, and but we require biopsy. We offered him a biopsy and told him all the risks of the surgery involved, and of course that he will require oncological treatment. He found somebody in another country who said they can resect it, and they did. And he came back with complex visual problems, and of course he required oncological treatment nevertheless. So one has to be sensible, well-informed, but also not necessarily do what patients may want doing. So here are the approaches that Ram has already described, and there's Professor Cinali will be talking about interhemispheric transitorial approaches, which I will not be talking about very much. So anatomy, because I'm here on behalf of IANA, that's why I like to focus on anatomy. So the pineal gland is essentially located in on the back of the fourth ventricle. As Ram has already said, the roof of the fourth ventricle is formed by the velum interpositum, which has two layers, and the lower layer is essentially stuck on top of the pineal gland. And there's a little bit of a recess of the third ventricle above the pineal gland, which is the suprapineal recess. And there is also a pineal recess, which is between the posterior commissure and habenular commissure. So here is a MRI scan, which I've taken from the internet, showing the posterior commissure, so posterior commissure here, habenular commissure here, with the pineal recess there. So and as you know, we'll add the vessels to it in a minute. That's the velum interpositum. We have lifted the fornices, and we see the internal cerebral veins and the medial posterior choroidal arteries underneath, within these two layers of the velum interpositum. If we go anatomically, of course, there's no tumor, there's an anatomical specimen. We depress the pineal gland and lift the velum interpositum. We enter the third ventricle this way. If we have a tumor here, essentially, this is not, you can't really identify the velum interpositum as such unless you go quite a bit anterior, and automatically you end up with the third ventricle at the end of a resection of a tumor. So if we add the veins, and this is one of the issues that we need to consider in pineal surgery, most of the great veins, i.e. the internal cerebral veins, which then join together with basal vein of Rosenthal and form the vein of Galen, are, as you can see, by definition, above the pineal gland. So the tumors that are pineal parenchymal tumors primarily, that there will, and any tumor that arises from the pineal gland as such, will be arising underneath of these veins and be lifting the veins above. Therefore, most of the tumors can be approached through the supracerebellar infratentorial approach. Of course, we have some veins on the way in, and this is mostly, as the Ram has mentioned before, the superior cerebellar vein, which picks up various veins draining the tectum and the superior cerebellar peduncles, and they have quite a wide anastomosis with mesencephalic and pontine veins, but of course we have to be always very careful with veins. I don't have really time to talk about veins now. If we consider the parenchymal tissue around, so here is again our pineal gland with the habenula commissure. Here the remnant of the velum interpositum, which has been removed, therefore exposing the third ventricle with adhesio interthalamica or interthalamic adhesion. We have superior cerebral superior colliculi, inferior colliculi, and fourth nerve coming out underneath the inferior colliculus. We need to know what is here, because the pineal tumor or pineal region tumor will often enlarge and invade the superior medullary velum, which is spread between the right and left superior cerebral peduncles. This is another specimen here showing the right and left superior cerebral peduncles in between superior medullary velum, analogous to the inferior medullary velum. They both meet at the apex of the fourth ventricle. So if we just look at it, from in different dissections, you can see again a fourth nerve underneath the textile plate with superior cerebral peduncles, inferior cerebral peduncle here, and middle cerebral peduncle laterally. Again, the fibers shown from the sort of supracerebellar infratentorial approach with again fourth nerve, which is a major landmark here, particularly when the tissues are expanded. Inferior cerebral peduncles, inferior colliculus, superior colliculus, and inferior cerebral peduncles here, inferior medullary velum there. Again, view from sideways, the inferior colliculus with inferior brachium going to the medial geniculate body. That's the lateral geniculate body of the thalamus, pulvinar of the thalamus here. And we don't have really time to go in detail what is inside of the midbrain in this area, but we need to know that when we want to do surgery, because we need to know of the consequences. Now you can see one of the configuration of the veins. This would be called the pre-terminal vein with superior cerebellar vein and superior vermin vein here. So as you can see, this vein that we kind of see usually from here onwards is not just draining cerebellum, i.e. vermis, as you can see here, but it also drains tectum. So we have to be judicious. In surgery on tumors, usually we need to take that, otherwise we can't really work sufficiently well in this area. And just to show the basal vein of Rosenthal running in the ambient system, then joining the great veins in the vein of Galen. So let's look at some examples here. So you can see hydrocephalus, some sort of even darker area than CSF, which is fat, as you can see on the MRI scan. And first thing we just did ETV. You can see that's the flexible endoscope, so really it's an old one. Massa intermedia, looking backwards now to the bulging mass into the third ventricle. And we'll soon introduce a monopolar and make a hole in it. But before we look at, you can see the mammillary bodies there, and ETV already performed as the entrance here to the, let's have a look again, mammillary bodies, ETV done, CSF flowing. And here is entrance into the aqueduct, and we're just going to buzz a hole in it. And as you can see, bit of fat coming out, and histologically it turned out, we'd taken biopsy of that, and it turned out to be dermoid. I'll tell you more about this case a bit later on. So supracerebellar approach. So that's what you do, for example, in this case, even if on the scan it seems that it would be difficult to get here, we can see that there's a cystic area, and very likely when we deflate that, we can then very easily bring the cerebellum down here and then have a view of the whole tumor. That's another view of that. We need to be mindful of the lateral extension of the tumor, but because we go from quite far away, we can, we can see the entire extent of the tumor fairly well. And so we've done that. Again, acute presentation here, but not acute, not too acute that the patient couldn't have an MRI before that, and then the patient underwent ETV, and then we did surgery 2 or 3 days later. Now, this one, for example, has a solid component. So if we went to go supracerebellar, I think we would really struggle. Of course, everything is possible. You can really retract very hard on the cerebellum, and then you will get that. But we want to do, as Rothan always taught us, a gentle surgery, because a non-gentle surgery has consequences. We can produce most of the time a decent MRI scan, but what we need to care about is the outcome of the patient. So here, for example, we did left-sided interhemispheric transtentorial approach. I won't be spending too much time on it, but sometimes it requires a bit of time. Just need to mobilize the vein, which is in our way, and because you probably remember the scan was quite a large tumor, so we need to make quite a large opening in the tentorium here, sort of along the straight sinus at the junction of the falx and tentorium, i.e. in the falco-tentorial junction. So there is already the tumor, but we're going to open the tentorium all the way anteriorly, so as we can deal with the tumor very well. And of course, in this case, the opening in the tentorium was very large. I won't be showing the resection because we just went and resected the tumor. I have no idea whether it helps or not, but we decided to put a little duroplasty on top of it as well. So just basically put one of the collagen grafts there and tucked it in on both sides, and there it is, and kind of reconstructed the anatomy there. It's probably not necessary, but we felt it was useful. So that's the tumor resected from that view. Now, sometimes, as Rana said, we inevitably encounter blind spots, and we can deal with the blind spots by retracting harder, or being a little bit more intelligent. And as in this case, I like to use an endoscope. Zeiss does nice endoscope that you can hold it's very light. And of course, if you want to operate behind the corner, you need to not only see behind the corner, but you also need to have tools. This is not one that I used in pineal surgery. That's sort of sometimes when you have a very lobular macroadenoma of the pituitary, you may require sort of various angles of suckers that you can adapt yourself in your hand. And that's this particular case of the pineal tumor, where we went again unilateral supracerebellar infratentorial, and resected the tumor grossly. And once we've done that, instead of resecting harder, we introduced the angled endoscope, look around, identified a small amount of tumor in the blind spot anteriorly on the posterior aspect of the fourth ventricle, and just sucked it out with the angle catheter. Now, in some cases, one approach is not enough. And again, if you push it harder, yes, you can take everything from one approach, but if you want to be respectful to the brain and other structures, and particularly in this area, you really ought to be respectful to pretty much everything. You may require 2 and sometimes even 3 approaches. I won't be for the sake of time showing it, but essentially, don't be shy to do staged approaches when you feel that you reached sensible limit of your approach. Thank you very much.
Beautiful, Mike. Congratulations for your picture and your videos, really beautiful. And now is the turn of my friends, Giuseppe Ginaldi, that will show us how to reach the pineal region. Giuseppe.
Thank you. Thank you. Can you hear me loud and clear?
Yes, yes, perfectly.
Okay, perfect. Thank you. Wait a second, I share my screen. Okay. And thank you to the previous speaker for a beautiful introduction and classification of lesions and approaches, allowing me to do a more technical speech about a pure interhemispheric transtentorial approach to the pineal region and to the posterior third ventricle. The advantages of the occipital transtentorial approach, as already shown by others, is the access to the third ventricle, to the superior cerebellar vermis, superior aspect of fourth ventricle, splenium of the corpus callosum, a better visualization of the third ventricle, no veins crossing from the occipital lobe into the superior sagittal sinus, so we are not bothered by bridging veins during the initial part of the approach, and no risk of venous infarction unless the surgeon divides internal cerebral vein. If compared in opposite with the supracerebellar approach, where it is known that a random complication can be the cerebellar infarction due to division of all the supracerebellar veins. This approach is relatively safer. This is how we choose the approach and why we prefer this approach. If compared to the supracerebellar, we usually consider the lowest part of the gallenus vein or the Gallen vein and the highest part of the Herophilus vein, and we straight line, design a straight line, and we can see that the whole tumor is located below this vein, and this happens in the largest part of the tumors of our series. So in this case, the approaches also make easier by the presence of the quadrigeminal cister is certainly to be preferred. In this animation of pineal tumor, we can see that with the Herophilus Gallen line, that is the limiting line on the upward gaze, we can have a very, very good vision of the whole tumor without problems and without limitation in the upward and the downward view. For larger tumor, like in this case, we can see that the Herophilus Gallen line can divide the tumors in two parts, but usually the largest part of the tumor is located below the Herophilus Gallen line. Why we consider important the Herophilus Gallen line? Because the Herophilus Gallen line is the line of sight of our microscope. Of the limiting point of the microscope, of course, is the presence of the torcular. We cannot go below the torcular, and the vein of Gallen. Of course, we cannot see higher or below the Gallen line, the Gallen vein, or at least we cannot easily work in such a deep access safely above this line. So whenever the tumor is located for the largest part below this line, then we are happy and we consider this patient as a good candidate to the transtentorial approach. This is what we can see below the Herophilus Gallen plan, and this is the volume of the tumor above the Herophilus Gallen plan to show that the volume, the largest part of the volume, is well located above this line. In our series of 30 cases, here are listed from the very, very smallest tumor to the very largest tumor. As you can see in order of tumor volume, you can see that the most of these lesions, pineal lesions, are mostly located below the Herophilus Gallen line. Therefore, we consider them as a good candidate for the occipital transtentorial approach. In our cases, in 30 cases, gross total removal through this approach was obtained in 33% at first surgery and 88% after the second surgery. I am especially grateful to the previous speaker for saying of not to be shy of choosing a second or sometimes even a third additional approach when we are facing a very difficult or big lesion, or where the child is very, very small, because sometimes we can obtain fantastic clinical results with the excellent resection in staged surgery, in 2 or 3rd surgery. Overall, in our series, a tumor volume above 2 square centimeters above the Rophilus-Galen line was predictive of incomplete removal at first surgery. So this Rophilus-Galen line is certainly a very good indicator and a very good predictor of the quality of removal. Preoperative preparation is standard. The control of hydrocephalus with the ETV or pre-existing shunt, of course, mostly we prefer, of course, the ETV. Standard preoperative, like a parents meeting, consent, a very careful shampoo, and also it is very, very important in our experience, the preoperative lumbar drainage, because the initial dissection of the interhemispheric fissure can be extremely facilitated by the opening of a preoperative implanted lumbar drainage. The position is prone with a Mayfield or a horseshoe headrest, no head flexion, must be completely neutral position, just turn 15 degrees to contralateral side of the approach. We have to be very careful in choosing the side of the approach. In this case, for example, we have to avoid the places where there is a significant asymmetry of the torcula and choosing the other side. 3/4 post position for adults or standard prone for children. We can see that with the head in this position, we can place ourselves on the side of the head and having a very, very comfortable position, both for ourselves and for the patient. You can see that we want to dominate the torcular. We want to dominate the sagittal sinus in order to make very, very easy the dural opening. You see that you have a sigmoid incision. This is the exposure. You can see here the sagittal suture and the lambdoid suture. We want to dominate and see very clearly the torcular aerophily and the sagittal sinus completely exposed inside the surgical field. And this is very important before dural opening to open the lumbar drainage, because in this position, in the prone position, the occipital lobe has a natural tendency to extrude through the dural opening. So it is very important to open the lumbar drainage before dural opening. We have to expose well, of course, the torcular, the lambdoid, and this gives the easy and straight access to the tumor, completely extracerebral. As you can see, we go into the interhemispheric fissure, we open the torcular, we enter into the quadrigeminal system, and then we face the tumor right in front of us. So it is a completely extra-axial, extra-cerebral, extra-parenchymal approach that can be really very, very clinically rewarding, both for the children and for the surgeon as well. In cases like this, of course, mannitol can be extremely helpful to reduce the consistency and the firmness of the parenchymal occipital lobe, open the lumbar drainage, avoid the edge of the retractors, of course, on the calcarine fissure. This is a very easy and stupid secret, but this is one of the most frequent mistakes. The edge of the retractors should not be placed on the calcarine fissure. This is the dissection. You see how easy it is after opening of the lumbar drainage. The occipital lobe is very much relaxed. We can expose very easily the edge of the tentorium, and we can retract the tentorium and see the arachnoid and the veins that are lying into the quadrigeminal cistern. At this point, we have to look for the quadrigeminal cistern and open the quadrigeminal cistern. So we must adjust the trajectory according with the navigation. We must see clearly the quadrigeminal cistern. That is a very, very important key for this kind of surgery. You see, I'm looking at the cistern, I don't find it. I adjust my trajectory according with the navigation, and I dissect the tentorium, and voila, here it is, the quadrigeminal cistern. I open the quadrigeminal cistern, and immediately I have a very nice flow of CSF, allowing for further significant detention of the occipital lobe. Release CSF at this time, wait at least for 5 minutes in order to have a very, very easy approach and a very significant spontaneous detection of the occipital lobe. At this point on the books, it is very easy. The tentorium is divided adjacent to straight sinus. The initial incision is made near the junction of the straight sinus and the torcular and is carried forward toward the incisura, and the venous bleeding is controlled with bipolar. All things that look very easy on the books, finally they are not so easy, and can be very, very boring to open the tentorium in the old way. This is an old film, old movie, where as you can see from the quality of the film, I was opening the tentorium with the scissors after monopolar or bipolar coagulation, but the bleeding was still important, and it was a very, very time-consuming technique. Now I coagulate extensively the tentorium with the bipolar, and I do not try to open it with a sharp instrument, but I prefer to vaporize the tentorium with a contact laser, and the vaporization of the tentorium with the contact laser is extremely effective. It is at the same time opening of the tentorium. You see that there is basically no blood at all from the tentorium and from the venous lakes that can be very boring and long to control when the bleeding is very significant. I can open the edge of the tentorium very nicely, and as you can see, I can protect what is below by pushing a cottonoid below the tentorium inside the cistern, and then going forward, we can see that we can open, accelerating the opening, vaporizing very, very quickly the tentorium and very nicely without a single drop of blood, and tailoring basically our tentorial opening with the contact laser. You can see that's really is very quick and easy and very patient tailored by the surgeon. And this is the approach to the problem of this approach as considered by many, the veins. This is the trajectory. This is the torcular going along the straight sinus. So we are approaching the quadrigeminal cistern, and here we are encountering our veins. It is not the vein of Gallen that we see immediately, but instead is the complex of the internal occipital veins that can block our vision at this level here. This is the vein of Gallen. Rosenthal is much more anterior, and this is the superior Vermian vein. So this is the figure of what we see, internal occipital veins that are here. This is the kind of vein that is bothering our view most. Internal cerebral veins are basically not seen during this approach, if not in very, very large tumor and only in the very distal part of the surgery. The Gallen can only be necessitated to be dissected in very large teratomas. Mostly we are dealing with internal occipital vein and the superior Vermian vein, sometimes with the Rosenthal. And we will see one by one. The first ones to dissect are the complex of the occipital veins and the right Rosenthal if we are doing a right approach. This is the packet of vein of the internal occipital vein that we are dealing. This is the occipital lobe, and you see how large can they be, and of course they should not be divided. The division of this vein is one of the most important reasons for the occipital infarction. You can see the right basal vein of Rosenthal is quite far away and anterior in this approach, and is not bothering us. The most important vein to protect and dissect is the right complex of the internal occipital veins. Then we have to dissect, after dissection of the lower right part of the tumor, we have to dissect the tectal plate and to find the third ventricle. Here we are in the lower part of the tumor. After dissecting the right part, here this is the tectal plate, and pushing up the tumor that we have dissected, we see that we are entering into the posterior third ventricle at this level. This tumor was very easy to dissect from the tectal plate. After finding the third ventricle, we cross the tumor with our, this is a teratoma, we are crossing the tumor with our navigation and with our cavitron, and we are finding the third ventricle across the tumor, and we know where we are. And after identifying the lower pole of the tumor and And where the third ventricle is in the depth, then our job is mostly done. But we have to deal with the superior vermian vein in the depth. Sometimes the lowest part, the lower pole is very adherent to the superior vermian vein. In theory, this vein can be easily sacrificed. This is the vein that by definition is sacrificed during the supracerebellar approach, but it can always be preserved in occipital transtentorial approach. You can see that you can dissect it very nicely, you can protect it, you don't have to sacrifice it with the occipital interhemispheric transtentorial approach, even in very, very large tumors, like in this very, very huge teratoma. Here you can see the superior vermian vein, the right Rosenthal that is very far away from our surgical field, and the internal occipital veins that are in the middle of the field, but can be saved throughout our procedure. Then we have Gallen. After removing part of the tumor and dealing with the upper pole of the tumor, we have to deal with the vein of Gallen. This is, of course, the most delicate part because we have to dissect the upper pole of the tumor from the lower surface of the vein of Gallen. Here, it is very easy in this case. Sometimes it is much more complicated than this, but in this case, it was relatively easy, and the tumor is easily detached by the lower aspect of the vein of Gallen, and we can detach the tumor like this. And then sometimes we are obliged to dissect above the vein of Gallen because the tumor has such a large and upper extension. Here you can see the splenium on the right side of your surgical field. Here you can see in the very middle the big vein of Gallen going out of the splenium, and here I am dissecting anteriorly and above the splenium at this level. After placing a retractor on the lower part of the splenius, I am dissecting the tumor from the above the vein of Gallen. Here you see that you can really do very significant surgery debulking above the vein of Gallen, above and on the other side of the vein of Gallen, and you can remove tumor like this. And having the vein of Gallen in the very middle of the surgical field, like in this case, you can really work on both sides of it, above and below, preserving it. And it is a very solid vein, very healthy vein. It is quite difficult to break it or to injure the vein of Gallen. If you keep it wet, you can see that it can stay in the middle of your field even for half an hour dissection without any damage and without any problem. So vein of Gallen can be dealt with relatively easy. Then we have at the very end of the surgery the left Rosenthal. Left Rosenthal is the most far away vein, and sometimes it is quite tricky. If you don't have done a good tentorial opening, dealing with the left Rosenthal can be quite tricky. In this case, you can see that because of the very good opening of the tentorium, I can see very nicely the left Rosenthal, and I can dissect the left Rosenthal from the capsule of the tumor. Here you can see the sharp dissection of the left Rosenthal from the capsule of the tumor. And of course, this dissection is time consuming. It's a beautiful dissection to do. Very extremely excellent anatomical exercise, should be done very carefully. And if your tentorial opening has been good and large enough, you can dissect even very far away in the most distal part of your field completely the left Rosenthal. You can see here the left Rosenthal completely dissected free from the capsule of the tumor. These are the Sephernia scissors that I prefer to use in a very deep field because they cut very nicely, but they are not sharp. So I can do very effective sharp dissection in the very deep surgical field. Then we have, after releasing the left Rosenthal, we are doing the easier part, that is the dissection of the left thalamus. It is very deep in your surgical field, but you can do it nicely because, of course, there are no more veins at this level. So you are safe, you are released, you are less anxious, less stressful dissection, just identifying the white ependyma and dissecting the last part of the tumoral capsule from the left thalamus and from the third ventricle. And in this case, you have released completely the tumor. And here you can see again the left thalamus completely dissected. and then removing the whole piece of tumor in one piece after complete dissection. These are some examples of large tumors of the pineal region operated through the interhemispheric transtentorial approach. Again, even if going above the Herophilus Galen line, we can remove completely this tumor in one single approach. And also in this case, even if the largest part is in the posterior third ventricle, if the line of the tentorium is high enough, allowing a good vision through a transtentorial approach, then you can really have a perfect control of the tumor. So evaluate your line of sight of the microscope before surgery. And also in this case, you were able to remove completely the tumor. So the take-home message is drain the CSF before occipital lobe retraction, because this makes really easier your approach. Favor brain relaxation with the opening of the lumbar drainage, a large opening of the tentorium to have a good control of the left Rosenthal, and keep the veins wet throughout the surgery, because this is a very, very important step and key to your surgical procedure. And you can see some videos recently published on this approach, free on the neurosurgical focus and on the Springer nature. Thank you very much.
Thank you, Giuseppe. Very, very nice speech. I think at the end we will have a very good discussion. And now is the turn of Albert Sufyanov that will speak about craniopharyngioma in children and the exo and endoscopic approaches. Please, Albert.
Okay. Good day for everybody. At first, I want to say thank you for organizers of this beautiful conference, just to give for us possibility to share our experience in craniopharyngioma surgery and pediatric population. And second one, I am really happy to see my old friends in this session. So Rames, Trinale, and so on. So thank you very much. And I really exciting about the lectures from our friends. It's really important, and I really enjoy. Professor Trinale's beautiful dissection of the pineal region. It's really beautiful. It's a big lesson for the residents, and not only residents. I'm really enjoy also. Thank you very much for lectures. But my topic is about the craniopharyngioma surgery. So please. Our experience, exoscopic. So now we use some new device, not only endoscopic, but exoscopic experience also.
I cannot hear you anymore. But I don't know if it's my problem. Perhaps some others, Giuseppe or other, can give their opinion, but I cannot hear you. I can hear your voice.
Sure. We repeat again. Sorry.
Most used classification is now we found the Stefan and Medjil in 2021. Surgical treatment of craniopharyngioma. So of course we have experience in all kinds of surgery. And in this slide, we present our algorithm for the treatment. So if you have the cystic part of the tumors is larger than the solid part, first step, we perform the use of Amaya reservoir. What means Amaya reservoir? Amaya reservoir is a special device. It is a port for ventricular access. In cases of craniopharyngioma with large cystic component, in order to decompress neurovascular structure, we use the implantation of the Amaya reservoir as the first stage of the neurosurgical treatment. And just for illustrate, I want to present some cases about this technology. I want to present the patient, female, 6 years old, is compliance of the visual impairment, more than on the right side, frequent headaches. This is the MRI before, with contrast, T1, you see big, huge cystic problem in cellular area. This is our operation room, just for equipment for this kind of surgery, just for Amaya reservoir making. You see the laser, and you see the operation file, how make incision. Because it's a small child, so it's very important, just bloodless surgery. You see the bloodless, very carefully, very carefully. Very important step. Usually we use monocautery. Now we create the space for the Amaya reservoir by the scissors. Very easy. Pocket, Carmen. And now we make a bar hole by the drill. And now another one is we use ultrasound navigation. And after under the ultrasound control, you see very, very well, we put endoscope inside of the ventricle, lateral ventricle. So any type of the ventricle, narrow, not narrow, possible if you have ultrasound control. Very easy and very precise then, without any damage. Now you see the anatomy of the craniopharyngioma child's brain. You see the Monroe, you see the septal vein, you see the wall of the cyst very well endoscopically. And now when you verify the cyst of the wall inside of the primary Monroe, we use the laser tube. You see the through the endoscope, and now we can fenestrate the cyst very precisely, just for the size of the ventricular catheter, because it is very important step. Not open the widely. If you open widely, not like size of the catheter, the contents of the cyst go to the ventricle space and create the meningitis. Very severe meningitis. So why? Second step is precise aspiration. You go inside of the cyst by endoscope and aspirate contents of the cyst. It's very important step again, because contents of the cyst is not good for the brain and may cause the meningitis. So we remove completely all contents of the cyst and then clean and washed by the physiologic solution. And you see, two assistants help me. One put inside the solution, other aspirate. This is the same contents, must be equal. And you see by endoscope the control. You wash before you endoscopically verified what all contents of the cyst you remove. And you, after that, you must verify the structure inside of the cyst very well. And now we verify the good decompression, because first ventricle is open, you see the mammillary body. So now the first ventricle is deblocked. Second step is we put inside the ventricular catheter by technique, by endoscope stilette. It's very useful by our endoscope stilette technique. We check the good place. We check the good place, and now we remove the endoscope. You see technique. It's very interesting. It's very easy and very precise. Endoscope stilette technique. And after, when you put precisely in your place the catheter, you connect the Amaya reservoir. Very easy. Just only ligate. and put inside of the space you create before the MI reservoir. Fix it and close the wound. This is our technique for MI reservoir making in patient. MI, palpate, location is okay. No kinking, for example. After that, we closing the wound. This is before and after. And you see very precise localization of the ventricular catheter. This technique I described for monocystic craniopharyngioma. Sometimes we have the multicystic craniopharyngioma. For this kind of craniopharyngioma, we use another option, and we install, for example, possible install 2 catheters option of this MI device for multicystic craniopharyngioma. You see on the slide very well. For example, you see the huge cyst. This is isolated cyst. You see the density is different. So no isolation between 1 or 2 together. This is before, this is after. You see, significantly reduce the cyst. So what I want to say about our experience about the reservoir catheter. Next step depends from the decision. If necessary surgery, so go to surgery. If not necessary, good stable condition, just only put inside some drugs. Like for example, Shlomi Konstantini explained us. Of course, we pay attention also for the endoscopic surgery. So endoscopic transnasal surgery we have also experience. This is our experience of endoscopic surgery. You see the total in this table. I show the result of endoscopic treatment. So we have experience by children and by adults. Near the 20 cases we have the children experience. Endoscopic is 7 and 15 children, 7, 15 adults. Most type is the Q type. And for children, total removing was near the 80%, subtotal free near the 20%. Somewhat about our endoscopic technique. So we have, of course, inside of the nose, basic anatomical landmarks. You see very well on this slide: choana, inferior turbinate, middle turbinate, nasal septum, for example, and so on. This is step by step how we go inside of the sinus. Of course, we must know very well the anatomical landmarks inside of the sinus, and but the previous lectures give us very beautiful anatomy. So I don't explain very exactly, but just only to show you. You must know very well internal carotid, optic nerve, calves, pituitary gland, clivus, and so on. Drill extensively if you want to operate very well and have a good corridor for this kind of tumor, because it's very challenging, very complicated by neurovascular structure. So you must open very well, not limit on the drill. This is my tips. Another, we have some anatomical features very important just for children, for children's transsphenoidal surgery. It's very important. In complex sphenoid sinus pneumatization necessity more drilling during surgery. So you see the size of the sinus during development of the child. The biggest size and volume is in adult, but one is a small child, so it's not so small. It's not so big. It's small. You see, but again. This is not absolute contraindication for endoscopic approach in pediatric patients. So only need more drilling during the surgery. Another very important issues is what the intercarotid distance. Again, intercarotid distance is established in early age in children and does not undergo significant change over the time. So, thus, children's age is not contraindication also for performing transnasal access. In cranioepiphyseal surgery, one of the most important is not access, not remove. One of the most important is how you close after surgery. So you must have very experience in the Haddad flaps technique, for example. Haddad flap technique is a standard technique for the close after surgery. Example of the treatment, surgical treatment, endoscopic. So we have not so many time, but the patient was male, 6 years old, and as first step for treatment, we implant the amide reservoir before. And you see before MRI before amide installation is a big cyst. Second stent, we put amide reservoir inside, and reduce cyst in size, stabilize the condition of the patient, and then go to the open surgery, endoscopic. You see the anterior of the sphenoid sinus. We open the corridor, endoscopic corridor. Just remove the anterior wall, and now we see the tumor inside the sphenoid sinus. Big tumor. Open the dura, cut by scissors. Remove the duras by the forceps. Additionally, we create open space. It's very important, not narrow, open space. No limit to drill to remove the bone, because if you remove bone, you receive freedom. And I drill more and more above. And when I open the optic nerves, tuberculum, I start to cut the dura. You see the ventricular catheter from the amide reservoir inside of the cyst. And now we start the dissect the cyst walls from the neurovascular structures. You see very carefully under the control of the visual control endoscopic. And when I understand it's not necessary, I must open more. So I must open more, make a stitch just to fix in open position the dura. It's easy to dissect after that step. And you see the very good structure, and after good visualization, because it's easy to dissect the tumor from Sarojan structures, and I understand when I remove totally, so I remove the ventricular catheter from the cyst. Only after understanding it's possible to total removal. And now I start carefully under control, visual control, sharp and dissection process. You see, very careful dissection. Very careful dissection. Now I remove the solid part of the tumor. All cyst, all membrane I save. You see lyric membrane, for example, intact, no recovery, but open the third ventricle, the total removal. You see now inside of the third ventricle, foramen major, choroid plexus, interthalamic adhesion. You see very well all landmarks. Another very important how we close. The first layer is spongostan, just to close the bottom, fenestration in the bottom of the third ventricle. And then because the opening of the third ventricle is a very big one, so I put the fat inside. And now we prepare the first celata just to suturing the defect in the dura. Stitch by stitch. And then we put the spongastan with the fibrin glue over the stitch place, just for liquid air preparing. And only this, after these steps, we put flap, Haddad flap. Also, fibrilla on the edge of the flap and fibrin glue. This is our technology for the close of the after surgery. And you see good result, total removing after surgery. And you see the very good nasal flap visualization after surgery and the follow-up time. And this is a nasal septal flap 4 months after operation. You see the endoscopic control and you see the MRI control. Very good visualization and very good survival of the nasal septal flap and close the defect. So it's very important. Nasal septal flap technique, very important, especially for young neurosurgeon. And another experience we have, a microsurgical technique. Microsurgical technique. Again, the position of the team, the main surgeon and 2 assistants, first assistant, second assistant. First assistant is standard assistant just for assist during the surgery. Second assistant just to manage the exoscope. I want to show the case. The patient female, 6 years old, come for us in very difficult conditions. And you see the big S-type craniopharyngioma, big one, completely filled. Third ventricle completely, MRI before. Dissect the supraorbital nerve by the ultrasound knife and carefully remove. After surgery, put in place without any problem. You see the optic nerve. And now dissect widely. So we create the space, big space, but not by distract the brain. By opening brain, like a book. Dissection, most important. And now we dissect also interhemispheric fissure also. You see, very wide.
Albert, these are beautiful movies, but we don't like to go late. So if you can conclude.
Both nerves, optic nerves. You see the A2 also. And now we have very good approaches from lamina terminalis, from interoptical, from optica carotid, for example, like this in this situation. So we try to remove tumors from all triangles. So it's possible to give us possibility for total removing. Good anatomy, safe completely. This is after total removing from supraorbital keyhole approach, minimally invasive, total. So in this slide, I want to show the adventures. Exoscope have a lot of adventures for the surgery. main is, I think, the comfortable position of the hand of the surgeons, because all this operation needs very precise moving of the hands. And again, this is only first step of development of the exoscope. We need a long way, I think, for improvement of the exoscope. So now exoscope have limitations, and young generation must pay attention for the improving of the exoscope. I think it's possible, and it's very near future. And in conclusion, I want to say what the treatment of craniopharyngioma is necessary to select tactics of treatment based on the location, structure of the tumor, and patient condition. So it's a complex decision. It's complex decision, not simple decisions. It's complex decisions, complex diagnostic, and complex decision. And after that, modern imaging techniques, endoscopic, help us to perform complex operation, reducing intra and postoperative risk of complications. So all must be complex, diagnostic and treatment, complex, and multidisciplinary team necessary for all this process. Thank you for attention.
Thank you very much. I think briefly we can have a discussion. I cannot see any question from the audience. I think we touched very nice topics. Well, there are some questions, but I cannot see because it is in Russian language, and so I cannot really see the first one is Chertek. Can you help me, Nasser?
I think over the chat we have some questions, and I don't know if you have seen this. Why using a transventricular approach when you can really put transcortical catheter? Who is going to answer this question?
No, this is a standard. For my reservoir, I don't understand the approach. What was the question?
The question is if you have a cyst in the craniopharyngioma that can be reached by a catheter through, of course, a stereotactic maneuver.
This is the transcortical, you know. But I explain our positive moments about our endoscopic pure control, because first one, you must create the size of the for the ventricular placement in the wall cyst is very important, because if big wider, so the contents of the cyst go to the brain, so it's not good for brain. So must be very tightly around the drainage. It's only possible by the endoscopic control, fenestration. And another one, we completely clear and we remove completely under endoscopic control 100% sure what we remove all contents by the endoscopic control also. And third one is we place in the right place the tip of the ventricular catheter. Also only possible by the endoscopic control, not possible by stereotaxy, for example. So this is the third main principle of the advantage of our technology.
Okay, and another question is if you have any intraoperative tricks to avoid the hypothalamus.
What again?
How to avoid the pituitary stalk and the hypothalamus?
Okay. We use, for example, exoscopies have some advantages. First one, you have very wide view of the exoscope, not like microscope, and illumination also good. Maybe magnification, maybe not illumination now, but magnification is very good. Another one is good dissection. This is like the Professor Cinali said us before in lecture, you must have good dissection of the arachnoid plate. This extra brains dissection must be. And you must see very well all perforators in the thalama cell area. It's most important. Even very small perforators. If you demate, you have a lot of problem. So why good dissection, extra brain, good dissection, and open the brain like a book, not brain tissue, but you must open the brain like a book. Why dissection? Arachnoid.
Okay.
This saves the perforator, all perforators.
Now we have two raised hand. One is Ashok Kumar. I don't know if Ashok can write his. And another one is Tarek Salem. Tarek Salem is the technique of repair of CSF leakage. How to be confident in postoperative period with and which technique of repair do you use? 3F or something like that?
It depends from clinic, it depends from team, from experience, but I try to show our technology in this case. So, but mostly I try to suture the fact that the fascia lata inside of the defect of the dura. Understand me? It's one of the best if you suturing the fascia lata inside of the dura defect. And I show in my video.
Yes, and I noticed that you are using endogenous material, fascia lata and so on, not exogenous material, is it?
Yeah, no, of course, no artificial. It's the best way, no artificial. Yeah.
Any other question?
But the most important is not to make the structure above the diaphragm. I have intraoperative CT in my hospital, and after I remove the tumor, I check by intraoperative CT the air inside of the cranial. If I don't have air inside of the cranial, so my operation is without the damage of the structure. So possible easiest way, that's only Spongestan, Tachocom, and et al.
Okay.
If you have air inside, so you damage structure. So air go inside, so you must suturing.
Okay, and the other two questions, which is the percentage of your patients requiring hormone replacement? And another question, which is very important, what is exoscope?
What again? Gorman therapies depend what's the tactic you use. So why we have not only one decision. So before the surgery, we have the multidisciplinary teams working, just estimate what kind of approach we use. Always we try to choose minimally invasive approaches. For example, MI reservoir, endoscopic, so on. And even if not possible, we go by the open surgery. But even in open surgery, if you see, we use some keyhole approach, like in my case I showed before. Again, exoscope not only for VU is device. It's device very useful for the ergonomic for the surgeon, because this kind of surgery is very long time and very difficult exercise, physical exercise for the surgeon, and you must have your hands very relaxed during all operation. Exoscope is an excellent device for this one, for this kind of during a long surgery, for example, because you move your head of exoscope in any position, just for you personally, for your hand personally, optimal. Understand me? No tremor, no, all time relax. Just for real microsurgery.
So we have several other questions. but I think we are a bit late. I don't know what you think, Nasser.
What is the scope? What is the scope? Yeah, the scope is new device. It's not microscope. It's new generation of the optical device now. Because microscope is now not first line. First line now is the scope. But for the scope, as I show again, is special device with 3D good magnification and illumination. It's very small, compact, and very movable, like this.
Okay.
It's very important, but it's also have some limit. Again, young generation. This is the first approach for the young generation now, not for the old guys.
Ergonomic surgery.
Yeah, ergonomic surgery.
Okay. We can go to the other session, Nasser.
Thank you, Marco Fontanella. Thank you very much for moderating this session. Thanks to all our speakers in the second session. Now it's time to move to the third session. I don't know, Anastasia, she's the moderator. Are you here?
Yes, sure. I can hear you. Can you hear me?
Yes, of course.
Okay, great. So I think we may proceed. My name is Anastasia Tassia, and I'm working at the University Hospital of Larissa in Greece. I would like to thanks and congratulate both Professor El-Ghandour and Professor Kenan for this excellent scientific and academic event. And as you realized, I'm replacing Professor Funtas because he had a previous academic commitment, so he couldn't be with us today. And without any further delay, I would like to proceed and introduce you the first speaker of this session, the third session, who is Professor Constantio Di Rocco. He's going to talk about craniopharyngiomas in children, and I think that Professor Di Rocco does not need any further introduction, so please.
Hello to everyone. I'm glad to be here to continue the discussion on craniopharyngioma after the previous presentation. So this is what we have achieved in the course of the year in the treatment of a craniopharyngioma. That is a very we are able to remove larger tumors, as you have already seen in the previous presentation. But even more important is that we can achieve this result with a minimal mortality compared to the past. But what we have to think now is not only to the management of the tumor, but to the quality of the life of the survivors, because we have as you have seen, we are able to remove this bigger tumor, but we have to think after the operation what happens. There is some things that we have learned. Is a benign tumor is rare in the cellular region, and for this reason can involve very important structures from visual function, the chronology, and the neurological function. Survival at 10 years is nowadays 90%. So the quality of life is very important. Another problem that affects children is that the great majority of these tumors are adamantinomatous tumors that have a retrochiasmatic location, calcification, and tend to recur more commonly. In the young children, we can find also very large tumors and the obvious hydrocephalus. What means adamantinomatous variant, a retrochiasmatic position? You can see a tumor that is the classical craniopharyngioma in front of the optic nerve, we have a large window to approach the tumor and to remove it. When we have the retrochiasmatic position of the tumor, mostly in children, we don't see the tumor in front of the optic chiasma, and we have to look for the tumor between the optic nerve, the carotid artery, so the removal can be more difficult. We have a considerably minor space to use. So just to express this concept, here you have a typical craniopharyngioma in children, and this retrochiasmatic, we have to go through the space between the optic nerve and the carotid. At the end, we have to use this kind of approach, translaminary approach. Again, what is important to think about this tumor in young children and this typical pediatric variants is that this tumor tended to calcify. So when you have to remove the tumor to the translaminar approach, you can always make damage to the brain, and you can see in the poster image that there is some sufferance of the brain. This is the typical appearance of a craniopharyngioma in children, a lot of calcium, like you can see. And this means that when you remove the calcified tumor between the optic nerve, the carotid artery, you can damage the wall of the vessel, and you can have more difficulty and some complication, that is the formation of pseudo-aneurysmal dilation due to the damage of the arterial wall. What we would like to have when we have a craniopharyngioma is to have this tumor located inside the cella turcica, no involvement of the hypothalamus, and then you can remove the tumor and having all the structures intact. But often you have this kind of a tumor that involves the roof, the floor of the third ventricle, and at the end of the operation, the floor of the first ventricle is no more intact. This means that you can have some endocrinological sequelae. And also we have to consider that in children, often the craniopharyngioma has some projection inside the normal parenchyma, like you can see here, and this explains why we have so many recurrences in the pediatric population, because of this digitation. So what we have this kind of a result, obesity, and even when you remove, for example, this tumor completely, the patient survive, but obviously you can see that has gained weight, and because of the damage of the hypothalamus, and even this complete removal that makes some damage to the patient, that's not assured that the tumor will not come back. So at the end, what you have to reoperate to fight this obesity that is quite difficult to control. Which are the other factors that can condition the operation in children is the very young age, that because when we have a very young child, we damage the hypothalamus, we damage the growth of the child. So we have a different attitude in a very young children compared to the older children and the adolescents. I said before that in the very young, we have often large tumors, and that also can give some additional problem. Like, for example, after the removal of the tumor, we have this large collection of a fluid that also can cause problems. Like you're saying, see here that this brain had some scars, not only for the operation, but because of this post-operative complication. If we see this picture shows the deficit, the endocrinological deficit before surgery, here are all the deficits, all the hormone deficit. After the operation, in almost all the case, they tended to increase for every type of hormones. And so you have a child that does not grow. We have to consider also that when we try to have a complete removal of the tumor, still we can have some operative mortality, we can have complications, and the post-operative hormonal deficit can reach almost 100%. Also high is the percentage of the neurological or visual deficit, and this, even with this deficit, we can exclude the recurrence of the tumor. So sometimes the operation is going very well, the child is cured by the total removal of the tumor, otherwise in other patients does not happen. So maybe we have to question if we are dealing with only one type of craniopharyngioma, or there are different types of craniopharyngioma. The same that happened for medulloblastoma, that at some time you could cure, and other times not. And nowadays we know that there are 4 types at least of medulloblastoma. Maybe also for craniopharyngioma, we could consider this a possibility independently for the numerous classification that have been made to discuss the risk, the post-operative risk. Which is the alternative of we can use a minimally invasive management of the tumor, which has a different goals, that is essential to decompress the optical nerves and the optic chiasma after aspiration of the cyst. And nowadays we can also use some intracystic agents to maintain the surgical results. In this approach, we should avoid to dissect the tumor from the hypothalamus. And it can be also questioned whether the preservation of the pituitary stalk is an essential steps. Also, we have the possibility nowadays of a more adapted radiotherapic treatment, which can also help and be taken into consideration when the risk of the tumor is considered too large, or for residual tumors. And as you can see, since 10 years ago, Kobayashi was able to control the growth of the tumor by focal radiation. The limit of the radiation is that the optic nerve and the chiasma cannot tolerate high dose, and the limit is actually 8 to 10 gene in a single session. Nowadays, another way to use radiation is to use a hypofractionatic, so to reach to remain under the 8-9 GI, but also to assure a good amount of radiation to the tumor. And we can see here in this case how the tumor progressively was reduced after this hypofractionated treatment. This is a series of Dr. Conti, and he could control the tumor in 87% of the case, maintain stable the visual function and also the pituitary function. So we should consider also this alternative besides our macho attitude typical of surgeons. We have to take into account that we can use the cystic component. It's not a new thing. Already Lexel did in 1951, the intracatheter injection of a radiotherapeutic substance like phosphorenoitrium, and recently bleomycin, that is an antibiotic. And this bleomycin was considered to be quite effective, but it's very dangerous for the brain. So if does not remain in the cyst, we can have a lot of problem. But which is the most important limit of this kind of therapy for me is that we are not aware about the long-term results. The series are very small, and then later results are not published. So nowadays we prefer interferon, especially because it's not damaging for the brain, it's not neurotoxic, has only mild transient effect, and is quite active against the carcinoma. You can see here a cyst, like was described before. You can put a catheter inside and then treat, make some injection of interferon, repeat injection, and at the end you can reduce the tumor significantly. We had this case in which we had this parenchymal reaction without any clinical symptomatology, but can be sufficient for me to question whether it's really not toxic for the brain. But another changes that is induced by interferon is that it changes the wall of the tumor, and you can see after having injected for several times interferon, we operate the tumor to remove the tumor completely. You can see the cyst, and other fluid is aspirated, and when we open the cyst of the tumor, you can see the wall is not the usual thin wall of the cauliflorizoma. It's a very thick, like you can see here, and this makes obviously the operation, because you have to detach the cyst from the surrounding structures, more complex than in normal cauliflorizoma. You can see how the tumor is like very solid. So obviously it's more difficult operation. We try to understand whether the introducing of interferon could be useful, and we had this series before using interferon. We had this kind of results. And this is a series of a semi-period after using interferon. So what we could see between this with this confrontation before this, when we were more aggressive, we could remove the tumor totally in about less than 80% of the cases, and the subtotal in the remaining 70%. When we use interferon, we reduce the amount of the tumor that was removed completely. The removal, subtotal removal was increased, and we had, in other words, a significant decrease of the removal, total removal of the cases because of this more prudent attitude. And what were the final results? That the more prudent attitude of had less mortality, less complications, and had less worsening of the patients, of the function of the patients, quite significant for the visual deficit, but obviously we had an increase of recurrence. So what do we do now? If we have two different attitudes, considering the age of the patients. If the child is older or adolescents, we try to remove the tumor completely and eventually treat the residual tumors. As for example, this patients is an adolescent as a tumor calcified. We resist the component and the hydrocephalus, we often tend to remove the tumor completely, and we can do using all this approach. In the very young children, we prefer to start with intracystic alpha interferon injection to control the growth of the tumor and to postpone the surgical excision of the tumor after puberty. That is, we try not to interfere with the growth of the child. So we have this tumor could be not difficult to remove this big cystic component and the small mass, but we tried to use this prudent attitude. We inject in the put a catheter in the cyst, and then we did the injection through a Meyer reservoir, which are very easy. By the way, we don't know the mechanism of alpha interferon has an anti-tumor effect, or it's just working because we remove the inflammatory effect of the craniopharyngioma, so the fluid. You know that just removing several times the fluid of craniopharyngioma, the fluid tends to become clear and then more, and the tumor can be controlled just by removing fluid. So we don't know actually how this is working. Maybe we hope that is inducing an apoptosis of the tumor. But in any case, there are some technical problems. That again depends on the characteristic of the tumor. We cannot generalize. Some walls are quite difficult to perforate, even under the direct visual control. And other time, we have to study before selecting this technique, how is the tumor and how is the cystic content, but the MRI examination not ever can predict if the operation is easy. So in any case, we did this initial experience, and we had 3 responders quite satisfactorily. In 3 children, the tumor tended to progress, and in one case I showed before, because of a parenchymal reaction, we suspended the treatment. So we had a technical failure in doing this. The responder, obviously, in the long time continue to be quite positive, and so we continue, and in one case, you saw we removed it. But when we decided to do the second step, that is when it's the right time to proceed to the aggressive removal of the tumor after interferon, I think it's not easy to establish. See, for example, these cases, this tumor, we did the pressure of the catheter, we did the interferon intracystic, treated the hydrocephalus, and then it seems quite satisfactory. The tumor was also reduced significantly. Then after the second cycle, tended to remain stable. And then after the third cycle, we had an impression that the tumor started to grow. And actually, this was the case. And we had to remove, but at that time, the tumor had to make an expansion because we did take into account this small presence of the tumor intraparenchymally, extension intraparenchymally. So at the end, we had to deal with a tumor that was more difficult to remove if we had probably removed before. So at these 2 points, the indication for aggressive surgery after a successful treatment by intracystic interferon. And then, even more important, is that we have to decide before operating if we can try to be aggressive or we should remain very prudent, and because we want to use a multimodal treatment. And this is, and concluding, we have this tumor that we see. Probably we should say that it's difficult to be removed, very adherent to all the structures, and but this was not the case. The tumor could be removed completely. I say this to stress how difficult it can be at the moment of the operation to decide whether to try to remove the tumor completely or to move towards a multimodal treatment and wait for the child to grow. Thank you very much for the attention. And this is the real risk, that at the end we tend to be less aggressive and maybe not remove a tumor that we could have removed with the first aggressive attitude. Thank you.
Well, thank you very much, Professor Di Rocco, for having for giving this meticulous lecture about the in-cystic treatment with interferon alpha. And I think that we have to proceed to the second speaker, Professor Matolese, who's gonna give us an update regarding the surgical removal of craniopharyngiomas in children. Sorry, Professor, you are unmuted.
Can I see my screen?
Yes, yes. Yes, sure.
It's good for you?
It's perfect.
So thank you so much to giving me the opportunity to speak on my experience about craniopharyngoma. Thank you, Professor El-Ghandour, to invite me, and thank you, Professor Anastasia, give me the possibility to give my talk. It is always very difficult to speak after a pope of the pediatric neurosurgery, but I will be, I hope that we'll be able to give you my feeling about craniopharyngoma. My conference a little bit long because Professor El-Ghandour said to me 20 minutes, but you can stop when you want because many things are already written. Craniopharyngoma is a
Sorry, Professor. Sorry, I'm really sorry, but we cannot see your slides now.
Yes, but and now?
Not yet. We were able to see one of your slides previously. However, now we cannot.
And now?
Yeah, perfect.
So craniopharyngoma
full screen, if it's possible.
Yes, I try, but it doesn't. It's good.
Yeah, perfect.
Okay, craniopharyngoma is an uncommon tumor, and it is a benign tumor, but it's a tumor that is very rare. So to have a great experience is always very difficult. Or people know this incidence is between 1.2 to 4% all primary brain in children. And if you look around in the international literature, we can see that in the United States is 1.20 or 0.43 per million, and a little bit more important in Japan, where we have 5.5 cases for year, with two peak incidence between 9 and 14 years and 50 and 74 years. But there is no difference of gender or race. In France, we have between 0.5 or 2 new cases per year per million of inhabitants. The symptomatology is well known, but when you have a good examination, you can see that there is many visual troubles, also endocrine problems. And at the beginning, you can see that there is a weight gain in 16% of the patient. The radiological aspect is typical, but we can show cystic form or solid form of mixed form, and this is very important. But what is more important, also Ezio Di Rocco said that in young people, these tumors are very large. And also, if you have a kystic component, these tumors go up or laterally. It is very important to know for the establish what we can do. In this, there is in many newborns this giant form, like in this case, in the other case, and like in this case, that in my opinion gave a little importance to all the classification that we can do at the beginning. What is important now is that we know better the biology of this tumor. In children, we know that adamantinous form that are typical children, and we can find also in adults, but papillary canopharyngoma are very, very, very rare in children. What is important that adamantinoma as a behavior like the developing of a tooth, like you can see in up, and while the papillary form is like in this case. What is important that in the two special form, we have the apparition of this form of genetic. And it's important that in adamantinoma form, we know that we have accumulation of beta-catenin, and in the papillary form, there is activation of the MAP kinase activity, and what is important, the BRAF mutation, la V600E, that means that this characterization that in the future, this is in my sense already late, we can treat this tumor with the pharmacological strategy. Canopharyngoma is difficult to approach because the anatomy where it's developed is very particular and difficult. But we forget in many cases that there is many important perforating vessels that came from the posterior perforated artery that are very important. It is very important to spare. Much important to spare little vessels that go to nourish the optical and chiasmal structure. Another point very important, it's very difficult to establish, exists or not a plane, a gliosis plane that was reported by Sweet in surgery of this tumor. When you look to the histological specimen, you can see that this plane for have a dissection exists. So, as Ezio said, surgery represents the gold standard for craniofaryngoma, but we have to establish when we can have a aggressive surgery or when you can stay more quiet, and to use our decision to go over a total surgical removal or a subtotal removal using irradiation or biopsy pre-irradiation. In my opinion, it's always very difficult in this surgery to establish when to have to stop. This is a very problem because this is an extra arachnoidal tumor, and you have always the impression during the surgery that you can dissect. So what you have to do is always very, very difficult to establish. I don't want to stress with the different surgical approach, but what I want to say that the new advantage surgery of this tumor came from the endoscopy and nasal transsphenoidal approach. Endoscopic, I am sure, increased our possibility, but I think that the use of technical endoscopy technique in children and very small children have to be cautious. There is also the choice of the surgical procedure. You can see in this form that is a very form that has Yazali reported of intraventricular craniopharyngoma. You can go through the ventricle. Yes, but when you arrive, you can see that here you have the floor of the third ventricle, and you pass through the floor of the third ventricle, so you can increase the problem after the surgery. Personally, I prefer the approach of my teacher, that is the subfrontal pteroneal approach. Why? Because we can expose all the four important basal triangles: the interaortic one, the optico-carotid triangle, the retrocarotid one, and also this fourth triangle that is very important between the cerebral anterior and sylvian fissure. This is what you can approach by the microscopic approach from the right side, and you can see during the dissection with the aspiration CSF, all the triangle can open to you to remove the tumor. It is sure that when the interoptic triangle is very large and the optic length is very long, it always is more easy. It's more complicated when you have a short net or a prefix chiasm. So we can use, as Ezio stressed, the translaminar terminalis approach. Like in this case, you can see this mixed form of craniopharyngoma with a large cyst. This is this is the approach we use to open large the sylvian fissure. We go after to discover the basal triangle, but in this case you can see the chiasma is prefixed, and so we have to open the lamina terminalis to start the surgical procedure. And you can see you have put attention, and when you start the suction of the cyst, also the other triangle can open, and so during the surgery you can move from one triangle to another. I agree with Ezio that it is very difficult if you have a calcified form, but in this case we have to wait or to reduce also with the cavity on the calcification and remove very with cautious the tumor. If you put attention, everything is well. In some case, you have to know when you have to go in another triangle. This is very important, but this is a question of experience. In this case, you see that the tumor is coming up without important problem, and so we can reduce it until to have a complete removal. This is the case after the MRI, after the surgical procedure, that show a complete removal. The problem with craniopharyngoma is also the individualization pituitary stalk and the respect to pituitary stalk. This can happen, but in many cases, in my experience, it to decide if you want to do a complete removal. If you don't cut the pituitary stalk, you cannot have a complete removal, and so you can expose to risk of recurrence. In other cases, I had the impression that I put out a very large tumor, but I had never seen the pituitary duct. This is my personal experience. So another problem is established that the relationship between the craniopharyngioma and the hypothalamus. And Puget in 2007 established this classification. But I think that also if this classification can give you a guide, each classification have to be confronted with the anatomosurgical aspect of the tumor. And in my sense, this classification have a reason to be mentioned because established that when you have a very great tumor, much more important volume too, much important can be the problem. In this case was operated, I think 10 years ago with a very important huge tumor. And I could remove this tumor with an approach from the left side because the left nerve was that still working, the other was completely without function. So you can see that you can remove a tumor, also a very large tumor, and this was happen at the end surgery. This is the left optic nerve. You get the carotid artery, is the basilar trunk. The removal was complete, but I don't see the hypothalamus. This patient had the severe visual trouble, but no hypothalamic problem. So it is very important that we can develop the endoscopic surgeries, but for we all people read the literature that this is very important for adult surgery. But for me, endoscopic surgery for craniopharyngioma have to be done only in particular case in craniopharyngioma that are in intracellular or little bit developed in the cellular, but on the midline, because there are many problems, and one of the problems of the endoscopic approach that you can have a mucosa that is very bleeding, very hemorrhagic. It is not very difficult to drill a non-pneumatized sphenoid sinus. I agree that the distance between the two carotid after 2 years of age is of at least 2 centimeters. Don't change many in the adult, and you can space. But what is important to stress that very large approach for endoscopic removal of craniopharyngioma in children give a high rate of CS fistula, and for me CS fistula is always associated with the meningitis. Meningitis in children is very difficult because a high rate of mortality with meningitis. This is a case that I have done. I am against very large opening of the skull base. You have to respect the limit, and you have not to open completely the put remover craniopharyngioma extended inside the third ventricle if you want to avoid the problem. You can open, you can see that you can approach the craniopharyngioma to put out the craniopharyngioma progressively. You can open and go with the endoscope inside to control the removal. But what is important for me is not to open the diaphragm cell if you would avoid also with a good closure with the mucosal flap the post-operative period. For problem time, I have to go. I have to show the control at the end with the good removal. But I want to stress this case. I didn't operate this case because he came from a country of the East Europe. He arrived in our service, the patient, because he had a severe meningitis. He was operated 3 times in his country for the problem of the meningitis without success. And I said, okay, this is a case where I can go to close this bone resection, and so I operate again by endoscopic approach. But you can see there is no tumor inside of the cell, and so I operated him another time. But the patient came back again 6 months after because it was not sufficient. I solved the problem with another approach, by transcranial approach. I could close the bone and pushing inside the cell by transcranial approach a great mass or muscle, and also to create a chicane technique, a closer of the cranium. For me, endoscope can be useful when you can have a revision of craniopharyngioma in that have a recurrence. And so in this case, I adopt a very happy to use the microsurgical approach with the endoscopic approach to go to see after the surgical removal that in the anterior part already operated, there was no more tumor. You can see the third ventricle, the floor, and also the operative field without the tumor. Another problem is the mortality. Mortality of craniopharyngioma is go now very low, but it exists. So we have to put attention to Norway carefully. The result of the literature, you can see that the change in the time. This is the ISPN of Schuchs in 1991, with 60% of patients with autonomous quality of life. And Ezio also in 1999 reported his experience, and you can see that the first time he noted that there is 70% of cases visual trouble, endocrine trouble in 95%, and neuropsychological trouble in 50%, and a rate of recurrence on 25%. Thompson in 10 years later showed that the result was better, but what worked better after the 1996. I think back in this period, all people was convinced of the utility of the microsurgery and the fact that the children have a particular approach for this tumor. But what is important, the same years also Zucchero presented his result, and you can see that with the rate of the removal was not much more important, and so we have to have this balance for surgeon that preconize a radical selection, and Elliott in 2010 affirmed that craniopharyngioma in craniopharyngioma, the surgical removal represents the best chance of a good result with a potential cure and a good quality of life. Incomplete resection, large tumor size, hydrocephaly, VP shunt represent, on the contrary, a negative impact on overall survival and progression-free survival. So we know now that when you go to very large tumor, you can create anteromedial and lateral hypothalamic lesion in the control area of the sacs and the food intake. So there is always this problem. And also there is also the contrary, that destruction of lateral hypothalamic areas lead to death for food refusal. So we have to stress that the hypothalamus is a cognitive and behavioral function is very important. But if you, I am convinced, and sometimes the hypothalamus is not where it would be to be. So we can remove, if you put attention and we don't create a ischemic lesion, a complete removal. So the possibility to have lesion with powders pushed to a limited resection with an adjuvant radiotherapy, and all people know the literature. But in the same time, Zucker reported that with a gross total removal in only patient with total removal were able to go to the school. He also Ezio revisited his experience and reported that of 54 patients, out of 2 all were in normal life and in good scholarity with a complete removal. So all people know that in this article of 2020, limited surgery by Kane and Merchant, limited surgery and radiotherapy represent 2/3 of tumor with favorable results. But if you look the problem that we have with the radiotherapy, we have to admit that exists social and emotional functioning lower than a control group, difficulty with learning, inability to control emotion, sensitivity to control emotion, concern regarding physical appearance. So radiotherapy is not always a good thing for a benign tumor. So we have to establish a gross total removal. It's possible, but we have to admit to recognize when this gross total removal is dangerous for nervous system. The other problem, and Ezio spoke before, this is the problem of recurrence that always present. And you know that if the tumor is more than 5 centimeters of diameters, the risk of recurrence is more important. So when I presented in 2005 my experience, we tried an alternative to a surgery direct approach. So I orientated to an intrasystem therapy, as Ezio said before. Because if you look to the morphology of the cranopharyngoma with intracystic chemotherapy, you can treat 8% of this tumor. This started with the report of Takahashi in 1985, and our experience with bleomycin and intracystic therapy was presented in 2001, many years ago. And at the beginning, we used a direct approach because we think that after we have to remove the tumor. But after the good result, we pushed only to put the Ommaya in endoscopic approach, but because in this case there is a large ventricle. But in a patient that have cystic lesion without hydrocephalus, we think that stereotaxis is a good option for patient older than 3 years. So on this point, you need with the bleomycin a test for tightness, and our result, because bleomycin all people know that is toxic, and you can inject between 1 and 5 milligrams every day after, and you can see that the result was very well. This is another case of a patient with the visual trouble that recovered completely, and you can see that you treated 19 patients, and with a good result. We have kept the volume of the cyst. This is a very large tumor, is a medial vulva, but the result was well. So we were very happy, but because also the quality of life, as you can see, were very nice, but we had a very important visual complication in Jackson and toxidose. We stopped the bleomycin. He accorded with Ezio Di Rocco that reported his first experience in 2007. We adopted the interferon alpha. The interferon alpha, in my experience, is very useful, but a very limited result in the time. So in this case, you know that the ventricle were very large, but the patient improved, but after the tumor growing again. So also this was also confirmed that the experience of Cavalerio more late also is not 2010 but 2016, and you can say that you can have a good shrinkage of the cystic lesion, but you have after a high rate of progression. And this was also confirmed that SIOPE and the ISPN study that showed that there is an escape to the treatment. The problem now in France, I don't know in other country, there is that the company don't give us the interferon alpha. I don't know why, because they have not the CA degree. So we had used another substitute that you can do subcutaneous, the Pediatric interferon B. So for me it was very important, but also with this drug, the results, as you see, are not very important and have an escape in the time. I don't want to speak about the problem of radiosurgery, because it is for me always very strange to treat a patient with radiosurgery, because there is also for radiosurgery there is some problem, the respect of the volume of the lesion, the distance between the optic nerve and the region of the hypothalamus, and you can see that in this paper there is some complication radiotherapy as optic neuropathy and brain necrosis, endocrine deficiency, second malignant neoplasm, neurocognitive and neuropsychological second, obesity or vasculopathy. So I want to show my experience, my involvement, my decision. We presented this first series of 54 patients, and you can see we have two groups of the patient, one surgeon on the left side of the screen. You can see that the result in patient with intracerebral therapy are much better for endocrinological point of view, from a visual point of view, and also for the scholarity. The problem that now, without the possibility to do bleomycin or without the possibility to inject interferon alpha, well, they have to go our decision. So I present a new series that is very short, because I consider this patient that were never operated for craniopharyngioma, treated between 2010 and 2021. So you can say I try to do the classification of Puget, and I was in the main number of cases for a transcranial surgery. Only one patient was treated with a transsphenoidal endoscopic approach. But you can see that also with my experience, the total removal was obtained only in 22 patients, 4 patients with a partial removal, and I speak of them after. You can see one tumor. This is the removal with a complete removal. And when you look to the results, 6 patients at the beginning have an obesity. Now I have 2 more patients have an obesity. But we have an important improvement of ophthalmological deficit, because they decrease only to 9 patients with that have 23% that have ophthalmological trouble. But all of these patients go to the school, except one that is not. And on 22 patients, 71 or to these 25 patients, there is a very good scholarity, and only 3 patients and normal scholarity but assisted. And there is no mortality in this series. But what is even more important for me, it is you can see the result in the time. This is at the beginning. This is after 6 months. This is at 5 years. But are not all the patients that are was possible to control at 5 years. But what is important for me, you have an increase of rate of obesity is sure. But the problem I cannot explain because this rate increase. And for me, it's what is very important to improve the assistance to this patient to avoid that they, also when they became from the pediatric age to the adult age, without a very good care, because I am convinced that with a good approach, the rate of this late obesity can disappear. So this is a series. You can see the follow-up that varies from 2 years to someone to 12 years, and 58% of these patients have followed of more than 5 years. So we have 6 recurrence on the 26 patients, and we have treated them 3 with a new surgery and only with a follow-up, and 3 had surgery that was followed by proton therapy for the DUT on the MRI of the control. Like in this case, that we tilted on the dizzy picture. We didn't know if it was a tumor or not. It was decided to treat this patient. But if you look, 23 of these patients are treated with only surgery, and this can be a good thing. So in my opinion, at the end for this talk, I can stress that actually in this situation when we have no clear idea about chemotherapy drug, we have to decide that for phalangioma you have to go to a surgery that have to be, for me, complete in each case. It is possible because also if you have a patient with some deficit, you can have a patient that is cured. It will be not exposed to the problem or another surgical or radiotherapeutic strategy. For the recurrence, it's the same, waiting for a drug that can be treated this tumor at the beginning without surgery. I think that the problem does not change. We have to be for complete removal associated, in this case, recurrence with radiotherapy. Thank you. For me, donc, the craniofalangioma remain a multidisciplinary tumor. With radiology, with endocrinology, with the surgeon, pathology, oncology, radiotherapy, ophthalmology, neuropathology. But I think that the position of the surgeon is very important to establish when you can remove a tumor and when you have not to remove a tumor. For me, this remain always very important. Thank you very much for your attention.
Well, thank you, Professor. You are absolutely right. And I have to admit, and I agree with you, that there is no time limit when you have to deal with such an important topic as craniopharyngiomas in children, which is rare, although rare, but benign, however, very malignant in behavior tumor. And without any further delay, I would like to invite the next speaker, Professor Solanki from Birmingham, to present and talk about the role of biopsy in diffuse intrinsic pontine gliomas.
Hello, Professor Tsiu and colleagues. Thank you very much for inviting me to participate in this amazing conference, and congratulations to all the previous speakers who have been absolutely amazing. I hope that I'm sharing my presentation. Is that right? And you can hear me. Okay. So I'm going to, I can't compete with the amazing presentations of surgical skill and which were masterfully performed. I'm going to simply talk about a biopsy. Okay. Somebody has to talk about the biopsy. So what I'm going to talk about is how a difficult tumor that previously was not possible to treat may show some hope through the advancements in biopsy in brainstem tumors. Of course, this is a very controversial topic, but I hope that I should be able to throw some light in it, and hopefully it would be something that we can move forward with. So my conflict of interest in this presentation is that I participated in a clinical trial and performed the brainstem biopsies that I'm going to talk about. As you know, the latest WHO classification, which is the CNS-5 in 2021, kind of supported the previous classification of pediatric type diffuse high-grade gliomas, particularly the name of DIPG, which is diffuse intrinsic pontine glioma, has now been changed and is now known as diffuse midline glioma, H3K27 altered. And of course, the other diffuse high-grade gliomas are listed here, hemispheric gliomas, H3G34 mutant, the diffuse pediatric type high-grade glioma, H3 wild type and IDH wild type, and the infant type hemispheric gliomas. And for the H3K27, as in all the other types, very detailed key diagnostic genes, molecules, methylation, analysis, all of that has been described, and I've highlighted those here. So, it's difficult to not say DIPG because we've been saying it wrong, but of course, the diffuse midline glioma, H3K27 altered, about 300 children are diagnosed each year in the US. Similarly, in other Western world countries, and overall, it's thousands of children per year who have the IPG. The characteristic radiological features very well known to you. Most of these children are diagnosed between the ages of 5 and 10. 5 is when they go to school. The IPG accounts for just 10% of the brain tumors, but 80% of the deaths from the brain tumors. And most of them will die, 90% will die within a year, 97% within 3 years. So it's a very dismal prognosis. And in terms of treatment, the only treatment that is standard is the conventional focal radiotherapy. And survival has remained unchanged in this tumor for more than 25 years. There is very few clinical studies that actually indicate that any of the current treatments are effective so far. So it's a most cruel and devastating disease. Firstly, we can't operate on this because the tumors are infiltrative between highly eloquent part of the brain. Then as we try to cure them, children with DIPG endure one experimental trial after another, usually suffering terrible side effects. And ultimately, it is with enormous cruelty that this disease takes its final toll. And the worst part is that they become aware. At the age of 5, they're actually quite bright enough to be educated. And so they recognize that their cognitive abilities, which they had just gained, start being robbed. One after another, they lose their motor functions. They become partly paralyzed, lose their voice, their sight, the ability to hear, the ability to eat and breathe. So it is really a cruel death that these children undergo. So as I mentioned, it's an enormous predicament. Now more than 6,000 people at any time live with this tumor. And what is the treatment? Well, for 40 years, we've not been able to treat this tumor effectively. We can't advance the case, the care of this disease because we don't have brain tumor material that we can diagnose. And this is why, we're here talking about the biopsy. So why didn't we biopsy it before? This is mostly for the medical students or the young doctors that are attending this webinar, because they might ask, but why hasn't nobody done anything? Well, of course we couldn't. The IPG is is in such a critical place in the brain. The tumors in children are uniformly high grade, so they're not likely to be treated effectively, and the survival time is just 1 year in 90% of the cases. And in the 70s and 80s, we did try to do these biopsies, but our tools were not as accurate or as effective, and multiple post-biopsy neurological deficits and problems kind of impeded further attempts at biopsy, because there was no treatment that a biopsy would be able to provide anyway. And this, of course, stalled research. No genetic or molecular studies were done. No new drugs could be tested. And this is why now, with the development of biological therapies, more and more oncologists, and this is a statement from my colleague Darren Hargrave from Great Ormond Street, is that we should, improve the standard of treatment for children with diffuse midline gliomas, and that, of course, includes doing biopsies. And so, if I take you to a background of why a biopsy is helpful, if you remember Stum's classic and one of the most popular papers in oncology, the epigenetic and biological subgroups of glioblastoma were defined, and particularly the K27, which unfortunately at the midline brainstem location occurred in very young children and at the poorest of prognosis. And then studies from Necker, Stephanie Pouget, Jacques Rille indicated the H3K27 trimethylation was involved in these tumors, and then that the tumors re-express embryonal signature at the midline locations like midline thalamic, hemispheric, DIPG. And subsequently, of course, we now have an array of the tumor types, some better, others worse, particularly the H3.3 K27 and H3.1 K27 amongst the worst. So now, and of course, Sturm continued his research and indicated that most of these K27 tumors in his paper were all midline, as you can see here: thalamic, upper midbrain, brainstem, pontine, and spinal cord. This is the histological appearance of the H3K27 altered. You can see the trimethylation is low. The H3K27 mutation is high, the P53 is high, EZIP and high, and BRAF is usually not identifiable, so normal. And then, of course, there is also the fact that within the diffuse midline glioma H3K, there are also the two types, one slightly better prognosis compared to the H3.3, H3.1, ACVR1. And then also in age groups, so the adolescent high-grade glioma in children has a G34 presence in about 60% of the tumors, as well as the wild type. So all of this can only be diagnosed and differentiated using a biopsy. And then, of course, the role for the biopsy then becomes more clear. We now know that stereotactic needle biopsies have a low risk of morbidity. Hardly any mortality has been reported in the last 20 years. The molecularly targeted therapies that are being developed for DIPG require biopsy to guide treatment strategies, depending on the particular methylation types and gene types. And because of scarcity of tumor samples, that research has been hampered, but we should consider speaking to patients and their families to advise them of the opportunity to donate, for example, leftover tissue to the International DIPG Registry or the research projects on tissue banks, so that collaborative work can continue. So not only the biopsy is useful for ensuring diagnosis, and often it may not be a H3K27 tumor, it may be a different tumor. And this is why biopsy is relevant, because sometimes in 20, 30% of the cases in multiple biopsy series, other tumors have been identified. At diagnosis, if you get the biopsy result, then you right up front, you have a guided therapy. 90% of these biopsies now allow successful molecular assessments. And as I mentioned, the safety, this is not anymore a life-threatening procedure. The transient neurological deficits vary from 5 to 15, permanent between 2 to 5. And of course, we mustn't forget the role of technology in brainstem biopsy. with the new advances in imaging, particularly in tractography, DTI, we now can accurately image the predominant fiber tracts, the corticospinal tract, the various decussations, and that then allows us to identify the relationship with the tumor. Now, this is actually a brilliant demonstration of this from an Indian paper in 2019 on a particular child. And you can see the DIPG and the fiber tracts quite nicely going around the identified diffuse tumor. This is usually the biopsy tract that one would use through the cerebellar peduncle into the brainstem. So all of this is making it easier for us to use for example, very accurate millimeter point precision by using stereotactic frames like this is the Lexcel frame, which then we could perform a biopsy on. This is, of course, the target is accurately determined on an intraoperative CT scan, so your accuracy is very good. Or you can use a robot. We use a Renishaw here, or the ROSA, and these are sub-millimeter accuracy. So the biopsies can be, improved technologically to reduce complications and risk to patients. Even then, there are questions. For example, this paper that was published about 10 years ago by Todd Hankinson. Who do you biopsy? And then, although in the case of a typical diffuse midline glioma, previously known as the IPG, it had been agreed that modern imaging provides sufficient information to reliably establish a diagnosis and proceed to therapy. There was considerable inconsistency in the part of pediatric neurosurgeons in the application of this strategy to individual patients. So very few actually would choose to biopsy a typical lesion, even though they said, yeah, I think this is the IPG, but they would not biopsy it. 18.3% would choose not to biopsy an atypical lesion. Even the ones that they thought, no, this is not the IPG, this is a focal tumor, they would still, only 18.3% would choose, 18.3 would choose not to biopsy. And only 69% would be willing to biopsy a typical DIPG. So, nearly 1/3 of the neurosurgeons would not biopsy a DIPG. This was 10 years ago, of course. And the point that was made in this particular paper was that the practice of diagnosing DIPG based on imaging characteristics and clinical history alone did not reach the appropriate threshold to be considered a standard of care. Because the accuracy of diagnosis pretty much, the neurosurgeons are reliant on the accuracy of diagnosis. Now, you heard this morning from Professor Diopijari and Serge Gurelishev that artificial intelligence is playing a bigger role in the way we treat patients. And this particular study is an interesting study that came out in 2018, where they reported, it's a very large study, of course, 151 patients, where they looked at over 1,697 features, and they reported an accuracy of 84.4% in the diagnosis of H3K27 mutation as an independent prognostic factor, conferring a worse prognosis. Now, of course, this sort of papers will start coming more and more, but I do not think that at this point in time, one can rely on AI to make accurate diagnosis. But that's the future. And then when we talk about the biopsies, is it just to make a diagnosis? Clearly not, because we are now seeing papers coming out talking about serial biopsies. So does the drug get there? Does it hit the pathway? Is there a mechanism of resistance? After you've given a treatment, if the treatment has not been successful, can we find out why? Has it been that the drug was inadequate, or did the tumor develop a resistance? These things can be diagnosed by serial biopsies. So this particular paper recently talks about targeting and therapeutic monitoring of H3K27M mutant glioma. And of course, I'm only talking about the IPGs here. This is another paper, serial H3K27 cell-free tumor DNA. Tracking predicts ONC21 treatment response and progression in diffuse midline glioma. So it's becoming vital that if we move into the world of biological therapies, we need to develop the tools and the metrics to optimize this sort of treatment. And this particular study indicates that liquid biopsy is been found to be effective in identifying the progress of treatment. And there are now a number of studies that are already ongoing for diffuse midline glioma. All of these studies would need some means of assessment of the outcomes and what is improving or not allowing improvement in those treatments. So again, biopsy comes to mind. And then the biopsy without harm. I mean, the patients, the families of patients who have died are regularly approached now to consider postmortem brain or tumor donation. Now, one recent institutional series demonstrated that approximately half of those approached consented to donation on autopsy. No families reported additional distress from the autopsy. Donor families generally reported deriving comfort from the hope that donated tissue could contribute to research. And the study also demonstrated that tissue adequate for analysis was obtained as long as 48 hours after that. So this is something that is, post-mortem, and certainly something that could help progress the study on this very difficult condition to treat. There are a number of registries, the International Registry and the CEOP Europe, the IPG registries. They have been collecting data on patients for a long time. It's a collaborative effort between North America, Europe, and Australia to centralize and standardize the collection of clinical data and tumor samples from these patients. And the goal of this effort is to support innovative research and ultimately find a cure for the IPG. And again, if they collect tumor samples and information on clinical information on the patient, so providing them with this information will only help develop research. This is one example of that. So this is a paper, a clinical, radiological, and histogenetic characteristics of long-term survivors of DIPG. So this is the point. If you collect data and a registry, then you can find out in large numbers of patients where they're long-term survivors of patients considered to be DIPG. And in this study, which was carried out, as you can see, by an enormous number of collaborators, what they found is that of about 1,000 patients with DIPG, 100, so 10% were long-term overall survivors, more than 2 years. And median survival for the entire cohort was 11 months, suggesting that there was a significant difference. And the overall survival for 1, 2, 3, 4, and 5 years, as you can see here, 42.3, 9.6, 4.3, 3.2, and 2.2 respectively. And what did they find? They found significant predictors of long-term survival in children with DIPG, included age less than 3 or more than 10 years, longer symptom duration, lack of cranial nerve palsies, chemotherapy at diagnosis, smaller craniocaudal tumor dimension, lack of extrapontine extension, lack of necrosis or ring enhancement on diagnostic MRI, and presence of the EAST1 HB3B mutation. Then the other clinical trial that we participated in, BioMIDI, run from Necker and around Europe, that trial is proof that surgeons can safely biopsy DIPGs and extract meaningful molecular knowledge. We have gone from no understanding of these lesions to having characterized all the major mutations. For the last 30 years, we were blindfolded, no progress against disease. Now, very serious questions on tumors can be put. And there is some hope for DIPG patients. So for once, we are now beginning to understand response to therapy. Consent for autopsy for when the children unfortunately die seems to be increasing. The samples of the same tumor from diagnosis and after treatment can help us to evaluate response to any treatment that has been given. So that is why it's so important. Even when we fail, we ask the parents to provide us with material. Understand the pathway the tumors use to escape therapy and how to block those pathways. As you all know, a number of therapies for pediatric high-grade gliomas are on the horizon, biological therapies. And currently, if you Google today, the diffuse midline glioma clinical trials, there are over 90 clinical trials across 127 countries. And they're recruiting. These are just some examples of the drugs that are being used for diffuse midline glioma. And there are multiple, you can see multiple collaborative. This is from the National Children's Hospital in Washington, including a number of countries, others single country, but increasingly multiple clinical trials are being developed. And what is happening is the biopsy, the brainstem biopsy is going to be the gatekeeper. If you don't do a brainstem biopsy, there is no entry into clinical trials. So it's become pretty much a mandatory thing that if you want to put a child that you consider to be a diffuse midline glioma, H3K27 altered, previously known as the IPG, into a clinical trial, the biopsy is mandatory now. So how do you do that? All decisions on biopsy of brainstem lesion should be validated on a tumor MDT with detailed appropriate consent about known risks, including that. The role, of course, is clear in midline diffuse gliomas as part of clinical trials, prospect of biological therapies. Focal brainstem lesions where diagnosis is uncertain, that's what we call the atypical DIPG. The radiological information could be a number of different tumors. It could be parasites, vascular, it could be inflammation. A biopsy comes in handy to differentiate those. And in these cases, then surgical resection may be appropriate actually in tumors or other conditions. And the caveat, of course, is that those who are going to perform these biopsies need to be trained with experience in stereotactic or robotic plant surgery and adequately recognized training. And they should, undergo that training to perform such biopsies so that the safety of those biopsies is kept at a very high level. So I'm going to conclude by giving the specific rules for the biopsy. So it's definitely necessary now for clinical trials, newly diagnosed and recurrent tumors. Without a biopsy, it's unlikely that biological therapies will become available to sufferers, de facto gatekeepers for effective trial conduct. And there is also a gap between clinical trials. So if you finish the clinical trial unsuccessfully, there are other trials you can enroll, but you need something like 6 months in between. And these children do not have 6 months. So again, there is all these issues. How do you participate in multiple trials on somebody who is only going to survive a year? So there are issues, and I think we have to all work together to try and resolve these issues. So I just want to thank Professor El-Ghandour and Professor Kanan for an outstanding webinar. I absolutely enjoyed it. And I think the presenters definitely showed their masterly control of neurosurgical anatomy today on multiple presentations, and which will make Professor Kanan very happy. And Professor El-Ghandour, thank you again. So I'm open to questions now.
Well, thank you very much, Professor, for this didactic lecture. And it is a fact that genetic targeted therapies gain ground more and more every day nowadays. And of course, we can easily realize and understand the significant role of biopsy when we want to deal and approach lesions in these scary, let's say, areas such as brainstem. So thank you very much. And I would like to invite our next speaker, Professor Panigrafi. He's gonna present and describe a special technique for the opening of dura in midline posterior fossa lesions.
Can you see my slides and can you hear me?
Yes, perfect.
Thank you, Professor Anastasia. I'd like to thank Professor Kanan and Professor Nasir also for giving us an opportunity to tell about our experience. We heard lifetime experience from Professor Carmine and Professor DiRocco of the craniopharyngioma. This is a very simple, short presentation on significance of occipital sinus when we do posterior fossa surgery. Conventionally, we open the posterior fossa in a Y-shaped manner, where the occipital sinus and the marginal sinus are usually ligated or coagulated and ligated. But then, as Professor Sinali was presenting, the importance of venous sinus, preserving the venous sinus is as important as preserving the artery. So we thought that whether we should preserve the occipital sinus while opening the posterior fossa dura, and what's the advantage of doing that? As we know that there is a high prevalence of occipital sinus abnormality, and if we try to ligate that in opening the dura, that can lead to logically a venous hypertension in posterior fossa and can cause cerebellar edema, and it can have post-op worsening because of cerebellar edema. There can be associated higher CSF leak because of CSF absorption defect, which I will explain with the comparison of doing a dural opening preserving the occipital sinus and the standard dural opening where the sinus is not preserved. Now this is the anatomy of the posterior fossa venous sinuses, where the occipital sinus communicates between the transverse sinus and the marginal sinus. Normally, it drains into the marginal sinus, and from the marginal sinus, it goes into the jugular foramen. And what we do when we open the posterior fossa dura is a Y-shaped opening where we remove the incise the occipital sinus here as well as the incise the marginal sinus. In turn, the draining of the occipital sinus is jeopardized. Earlier, we thought that in the occipital sinus normally it reduces or disappears in adults. Like in MRV, they found that in children who are less than 2 years, 41% of them had the persistence of occipital sinus. At 9 years, it became 18%. And in adults, it was assumed that occipital sinus does not exist. But then when people did MR venogram, they said that 45% of them had a preserved occipital sinus. And when people did the cerebral angiography, almost 90% of them in adults had the persistence of occipital sinus. So in cadaveric studies, almost 100% has preservation of occipital sinus. So assuming that occipital sinus is benign and sacrificing probably is not the right way to do. Now, this was a paper on a dominant occipital sinus, which complicated the surgery because that both, as you can see here, that both the transverse sinus was absent and all the drainage was dependent on the occipital sinus. So in these cases, if one sacrifices the occipital sinus, we can have post-op cerebellar edema, hematomas, as well as CSF leak also. Now, the incidence of this oblique occipital sinus or prominent occipital sinus is not very low. In a CT venogram, the incidence is almost 2.3%. And MR venogram, which Kobayashi had published, it's 4.7%. So 1 in 20 of the patients which we operate probably will have a oblique occipital sinus which has to be preserved while opening the dura. And especially when you operate in a prone position because of neck flexion and because of the pressure and the intrathoracic in the prone position, the venous there is a increase in venous pressure because of the position of neck flexion. And in addition, if you disconnect occipital sinus, it will increase or aggravate the venous hypertension. And if the tumor vein also drains into the occipital sinus, and if you try to sacrifice the occipital sinus, it can have catastrophic venous hemorrhages and edema during the surgery, and surgery can be difficult. And once we do sacrifice the sinus in a prominent occipital sinus, there can be malignant cerebellar bulge, which can cause difficulty in surgery, and you can have morbidity and mortality because of that. And if the G lymphatic system, if you understand the G lymphatic system, where all the CSF, it gets absorbed through the perivenous space, and when we have a venous hypertension, that can cause hydrocephalus as well as secondary CSF leak and pseudomeningocele in this group of patients. We already know that in Chiari malformation, these venous anomalies are higher, and people have changed or modified the dural incision to preserve the patency of occipital sinus in foramen magnum decompression. What we try to do is we extended that principle into posterior fossa surgery of opening the dura, preserving the sinus. This was a pilot study we had done. We had published in 2012, where this patient with posterior fossa tumor who had absent transverse sinus and a prominent occipital sinus, we open the dura in a crescent shape. Instead of doing the Y-shaped opening, we open in a crescent shape where the sinus is marginal sinus is sacrificed only at one point. So the venous drainage of the occipital sinus is preserved through the marginal sinus to the jugular vein. But then it does not reduce the exposure of the area of interest. So we have done for more than 100 cases that our extent of excision has not changed, whether we used a Y-shaped incision or a crescent incision. And usually we do the crescent on the non-dominant side of the marginal sinus. Now this is a short video of how we open the dura crescent shape. You start opening on the lower side. When you open on the lower side, you can the CSF also releases so that the opening the dura on the cerebellum becomes easier. You don't have when you do a Y-shaped opening, usually you open on the upper part where the cerebellum keeps bulging out. But when you open this way, because the CSF is let out, the cerebellum becomes lax and the dura opens easily. It is like letting out CSF in a CT angle tumor from the cerebellomedullary system. And this is how the closure looks like. The closure as on the marginal sinus, we open at one place, and the venous sinus is not sacrificed, it's occipital sinus, so the dura is preserved. So primary dural closure can be achieved in all the cases, and we usually don't need a duroplasty, as you can see in this video. So it's easy to close without duroplasty. So again, the dural closure is done from below up, and this is the upper part near the transverse sinus. No traction, no duroplasty. Good dural closure like a supratentorial dura. So this is how it looks like, that the venous, the flow is preserved, and without at the end of this is at the how it looks at the end of tumor excision. So what we achieve is it reduces the need of duroplasty, and it reduces because the venous return is preserved, so CSF absorption is better, hence chances of pseudomeningeal or CSF leak also is less. So we compared 29 cases of Y-shaped durotomy with 75 cases of crescent-shaped durotomy. What we found was that the chance of CSF leak in crescent was 1.3 as compared to 6.9% the Y-shaped, and the pseudomeningeal formation was 2.7% in the crescent as compared to 17% in Y-shaped durotomy in our group of patients. And this we published in 2019. We have used this in posterior fossa tumors, but then preserving the sinus is also important in occipital screw fixation in CV junction anomaly. So this was a paper came in 2016, where they did DSA for all the patients, and they have classified the occipital sinus into 4 types. One, type A is absence of occipital sinus, type B is single in the midline, type B2 is paramedian, and type C is bilateral, and type D is multiple. And the commonest one is the paramedian one, as we found in our observation, that most of the time it's off the midline, like 31% off midline, and hence doing a crescent-shaped incision is probably better than doing the classical Y-shaped incision, which we have been taught long ago. In addition to the crescent-shaped opening, when people operate in a sitting posture, in a supine posture is not a problem because it follows the normal flow of the venous drainage. But in a sitting posture, there is reversal of the venous drainage. In turn, it totally depends on the marginal sinus and the occipital sinus on the venous drainage. So if one, especially in sitting posture and patients with prone position with neck flexion, it's important to preserve the venous sinus to have the venous outflow. In conclusion, occipital sinus preserving dural opening can reduce operative and post-op complications. Preoperatively, it's always better to do an MRV to decide on the dominance of the occipital sinus and the dominance of the transverse sinus, and then decide the side of dural opening. Usually, crescent dural opening is performed on the non-dominant side, but if there is no dominance, it's co-dominant, then one can decide on the side of the tumor. And if the occipital sinus is not visualized, then again one can open on the non-dominant of the transverse sigmoid sinus. And in case of emergencies, one can decide where MRI is not available, one can decide on the location of the tumor. Thank you for your attention.
Well, thank you very much, Professor, for sharing with us this very interesting and useful durotomy technique. And we all know that it is very important for us neurosurgeons to preserve the venous outflow during our procedures. Thank you again. And I would like to introduce our next speaker, Professor Daoud. She's going to speak about and give us an overview regarding ependymomas of cauda equiana in children. Is Professor Daoud, can you hear us?
Yes, I'm here.
Great.
Good evening.
Yeah.
Good day, everybody. Nice to meet you, Anastasia.
Thank you.
Thank you.
Nice to meet you too.
Yes.
We cannot see your slide yet.
Can you see my screen?
Not yet.
Not yet?
Yeah, now we can see your presentation, but it's not in full screen.
We'll start now. It's
okay. You can see my screen now?
Yeah, I think it's trying. It's working, not yet, but it's working.
It's working, yes.
Yeah.
It's coming, it's coming.
Okay.
invitation.
Again, we, yeah.
Yes.
Yeah, perfect.
Thank you. Thank you. So, good day, everybody. Yes. Thank you, Anastasia. Thank you, Professor El-Ghandour, for the invitation and for this interesting scientific meeting. So today I will talking about ependymoma of cauda equina in children. I start with the introduction. Spinal tumors are relatively rare, accounting for only 5 to 10% of central nervous system tumors. The vast majority of the spinal tumor are intradural extramedullary in location. Ependymomas represent over 90% of primary intradural tumors in the conus medullaris, cauda equina, and the filum termina. The last of these are the myxopapillary subtype. Is the most common neoplasm in the conus and the cauda equina, accounting for 83% of tumors in this region. Is less common intradural extramedullary lesion, originally described by Kernohan in 1932. Epidemiology. The overall incidence of primary intradural extramedullary ependymomas is quite low, with than 20 cases reported in the literature. Some of these were multifocal, while others were myxopapillary ependymomas. Occur in all the last occur in all ages, with a mean age in the mid-4th decade of life and range of 3 weeks to 82 years. Myxopapillary ependymoma in childhood typically occur in the central nervous system. There are few surgical cases of myxopapillary ependymoma of the coda equina in children. There is a slight male predominance, and it is more common in white than other races. Pathogeny? Myxopapillary ependymoma is a subtype of ependymoma that is typically intradural extramedullary in location and constitutes the most common tumor in the conus and the coda equina region. It is generally less aggressive than other types of ependymoma, although it has a tendency for local recurrence and intrathecal metastasis may occur. It most often occurs at L2, followed by L1 and L3. Myxopapillary ependymoma frequently spans an average of 4 vertebral segments. Those tumors occurring near the sacrum may be associated with large areas of bone destruction. Myxopapillary ependymoma is to arise from ependymal cell rests normally present in the phylum terminal due to the extrusion of ependymal cells before neural tube closure. Histology. A grading from the latest Wood classification of tumors classifies ependymoma into grade 1 as subependymomas and myxopapillary ependymomas. The last one is most frequent subtype in coda equina, conus grade medullaris or phylum terminal. The who grade 2 are ependymomas, grade 3 are anaplastic ependymomas. Macroscopic features of myxopapillary ependymoma are well-defined elongate sausage-shaped tumors with a smooth surface. Some are encapsulated and usually displaced or compress the adjacent coda equina nerve roots. Microscopic features of myxopapillary ependymoma has a distinctive cytological, it organized papillary structures with palisade of tumor cells arranged around the bronchus vessels. About the immunohistochemistry, myxopapillary ependymomas are usually diffusely expressing GFAP and vimontin. They are also positive for mucin. About the biology molecular, very few isolated cases with specific molecular and cytogenetic abnormalities have been documented. The clinic. The nerves of the coda equina region include the lower lumbar and all the sacral nerve roots. Functions of these nerves include sensory innervation to the saddle area, voluntary control of the external anal and urinary sphincters, and sensory and motor fibers to the lower limbs. Patients with myxopapillary ependymoma most commonly present with low back pain, radicular or sacral symptoms. Weakness and sphincter dysfunction are less common. The usual initial presentation of low back pain and the lower extremity radiculopathy is no specific, mimicking discogenic disease and contributes to the frequently delayed diagnosis of myxopapillary ependymoma. Large tumor may be associated with irreversible neurologic deficit. So there is often a delay in diagnosis due to slow growth. Radiology, MRI is the best technique for imaging coda equina myxopapillary ependymoma. So it is usually T1 isoenthos 2 cord. Less often it is T1 hypoenthos or hyperenthos with the latter due to the presence of mucin or hemorrhage. And it is hyperenthos on T2 with enthos homogeneous enhancements. The differential diagnosis of myxopapillary ependymoma include both neoplasms and non-neoplastic disorders. The first differential diagnosis is schwannomas of the coda equina. They may appear identical to small myxopapillary ependymomas. Schwannomas involve dorsal sensory nerve roots. So clinically, they present with radicular pain or signs related to nerve root or cord compression. Morphologically, schwannomas are nodular lesions that demonstrate T1 iso or hypointensity and T2 hyperintensity relative to cord. The presence of the multiple lesions should promote consideration of neurofibromatosis type 2 and schwannomatosis. The second differential differential diagnosis, the meningioma. So the vast majority of spinal meningiomas are thoracic, followed by cervical and lumbar in location. The conus, the coda equina location typically of myxopapillary ependymoma is uncommon for meningioma. Meningiomas broad dural attachment may allow differentiation from small myxopapillary ependymoma. However, a large myxopapillary ependymoma, even through not dural based, may broadly abut the dura, making it difficult to distinguish from a meningioma. Most meningiomas are hyper or isointense on T2, intermediate to hypointense on T1, and demonstrate strong homogeneous gadolinium contrast enhancement. The third differential diagnosis, paragangliomas. So the paragangliomas of the coda equina are rare, benign tumors, except for cases of secreting tumors. The preoperative diagnosis is difficult. MRI is useful and may reveal radiological features suggestive of these tumors. However, it is rare for the diagnosis to be made before surgery. The diagnosis established by histological examination and immunohistochemical techniques must be used to confirm the diagnosis. Other differential diagnosis, we have malignant peripheral nerve sheath tumors can mimic schwannomas but are more aggressive. Non-neoplastic disorders, including dermoid, epidermoid, and disc herniation, should be considered in the differential diagnosis of myxopapillary ependymoma. Today are not commonly intradural. Treatment. So the treatment of the ependymoma of coda equina, surgery is the gold standard of treatment for symptomatic myxopapillary ependymoma because complete excision can be accomplished and cures can be achieved. When possible, gross total resection of myxopapillary ependymoma is the treatment of choice, providing a potential cure without the need for adjuvant therapy. 85% of myxopapillary ependymoma in the coda equina can be removed totally. The role of radiation therapy has not been adequately assessed. It may be necessary if there is subtotal resection or recurrence. It is used in patients who have undergone total resection, and for those with extradural ependymoma is controversial. Chemotherapy is indicated only in those patients with recurrent disease that is refractory to resection and irradiation. What about the prognosis of myxopapillary ependymoma? So, myxopapillary ependymoma typically exhibits relatively benign behavior and more favorable prognosis compared to ependymoma curing within the spinal cord or brain. The extent of surgical removal, tumor location, and the integrity of the tumor capsule determine prognosis. The 5 year survival rate after complete or partial resection is 98.4%. Metastatic period of myxopapillary ependymoma is uncommon. When it occurs, it tends to spread restauravely within the central nervous system, with the intracranial location the most common site of metastasis. Caudal spread as drop metastasis may also occur. So the long-term follow-up is necessary since metastases have been reported up to 20 years after initial treatment. Myxopapillary ependymoma may be more aggressive in children with distant spinal and myxopapillary ependymoma may be more aggressive in children with distant spinal and brain metastasis more common than in adults. So we present now one case, illustrative case about myxopapillary ependymoma in children. Is about 5-year-old boy presented with walking the line, walking with help on tiptoes. MRI performed imaging made the sagittal member spine showed a hypointense intradural spine canal, mass on T1, and showed a wide enhancement. So the patient was operated. The surgery is performed under general anesthesia. Patient placed in prone position. We have performed the laminoplasty. So the posterior vertebral arcs are cut in a block from top to bottom with the craniotomy. Then they are replaced during the closure fixed by wire. Here, donc, release of the nerve under microscope. We have, and here we have total removal was successfully achieved. So, so this approach promotes healing and prevents spinal deformities. Here we have the tumors. The histological exam indicates myxopapillary ependymoma. Here he replace the posterior arch. So the post-operative follow-up was favorable. Follow-up MRI performed at 1 month and 1 year post-operatively showed no tumor residue or recurrence. We conclude that ependymomas is the most common tumor of the poda equina region. Early diagnosis is important because larger tumors are associated with recurrences and worse functional neurological outcomes. It's a tumor who should be removed completely if possible. Thank you. That's all.
Well, thank you very much, Professor, for this meticulous overview regarding ependymomas of Cauda equina. And I think that the key point is what you said in conclusion and in your sum up, that there is an underestimation regarding the diagnosis of these lesions, and this is very important, and we should be aware of, especially in children, because the long duration of the symptoms might be responsible for a less favorable outcome in these cases. And at last but not least, I would like to invite Professor Sokolovsky, the world champion, I guess, from Buenos Aires, to talk about the management of children suffering neurofibromatosis 2 lesions.
Hello, thank you. Thank you for this sportive allusion, my person. Can you hear me and listen me well?
Yes, we can hear you very clearly.
Okay, we'll start sharing my screen. Please let me know if it works.
We can see we need full screen though.
Yes. Okay.
Perfect.
Is it okay? Well, I will speak as fast and as short as possible about something which is outside the brain, as pediatric nerve tumors are. So you know that we can divide peripheral nerve tumors between not neural and neural, but we can start to forget about this and just focus on certain tumors, which are the well-known schwannoma, neurofibroma, and the malignant schwannoma, which is now called malignant peripheral nerve sheath tumor. So a schwannoma is something like that in the upper side part. The solitary neurofibroma is more adherent to the nerve, but still can be dissected. And the plexiform neurofibroma is something that is characteristic of pathognomonical from neurofibromatosis. So sometimes it is very difficult to differentiate, not only surgically, but also after in pathology, a schwannoma from a neurofibroma. And of course, we have those plexiform schwannomas which affect the face or some other places that are very pathognomonical, as I said, of neurofibroma. A malignant peripheral nerve tumor. The first and most important thing is to using anamnesis, inspection, palpation, and of course complementary studies. So look at this screen. I will turn off the sound. Look at this screen. Well, this tumor is moving, especially in the perpendicular plane. So probably it is a benign tumor because it can be mobilized very easily. And so complementary studies includes MRI, of course, and PET scan. In MRI, we can really see the tumors. As here, tractography also helps to know where the fibers are. And in some cases, they can define malignancy. For example, those tumors that are bigger than 5 centimeters, which has an heterogeneous enhancement and irregular margins. So in any case, MRI does not replace pathology. So you always should have a pathological biopsy. What about PET scan? Same happens. We can find some things that make us suspect a malignancy, but anyway, it does not replace anatomical pathology. And this has been studied and well published in the literature. So what about benign tumors? We can do the surgery we want to do, which is complete resection of the tumor and nerve preservation. What about malignant tumors? We should be oncological, which means we should call another colleague from the oncological department and make a complete surgery with oncological margins. What does this mean? This means that nerve preservation is secondary, and we should, in many cases, in most of the cases, take out the nerve. So this is a benign tumor. do not cut the nerve, dissect the tumor, preserve the nerve, and that's the point. If this is a malignant tumor, we have to take it out, including the nerve, okay? So a benign tumor, as I said, and you can see here in this video, under stimulation, you can isolate the fascicles, the working fascicles of the nerve. You see the foot is moving, this is the sciatic nerve, and with the stimulator, you can see very clearly the difference, and also with the visual loops or microscope, you can aid to start to dissect the nerve and take it out completely. And as you can see, look for the fascicle that gives growth to the nerve, take it out, preserve the nerve, and take completely. And this is the final situation and the desired situation: a functioning nerve with the tumor outside the body of the patient. This is another patient with NF1. It's a young boy who had median nerve sensory symptoms. This is the median nerve, okay? So you see there is a big nerve, big tumor raising from the median nerve. So this is the surgery, and because this patient had a 4-year evolution of this big tumor, we knew that this was a very benign tumor, so we could dissect as we like the tumor from the fascicles and under stimulation preserve completely the nerve and take completely out the tumor, as we are doing here. This is a microsurgery, do not forget. And we can take out the fascicles, as you can see, very easily with microsurgical forceps. This is the tumor and the nerve relation. And this is, as I said, the nerve preserved and the tumor. And this is the patient with complete preservation of the motor and the sensory function. And also the opponent is preserved, which is part of the median nerve. This is the scar. So in malignant tumors, as I said before, we have to do a complete surgery with oncological margins. And you can see here some pictures of some of those patients, unfortunate patients, who needed to have a more aggressive surgery, including the nerve, as you can see here in the photos. So what about NF1? When should we do a surgical resection? And this is very clear, and we have at our hospital, the University of Buenos Aires School of Medicine Hospital, the Neurofibromatosis Center, where we treat many of these patients, and we arrive to this kind of conclusions. Many surgeries is not always the best, because for a patient who has a genetic disease, this can be ominous. So we just do patient surgery in patients with sensory symptoms, motor symptoms, and this is especially important because motor symptoms are associated with malignancy, and of course, tumors that grow very fast. And that means, of course, again, that they can be malignant. And perhaps, and this is subjected to discussion, when the patient have aesthetic problems. So we have also some drugs in the market, like selumetinib, which was accepted by FDA in USA, but not here in Argentina. Trametinib, which might be also used, which is not as accepted by FDA, but yes, in Argentina, it changes country by country. So I will just show our experience, but this is subjected to change, of course, and it's very dynamic. And bevacizumab, of course, in NF2 for vestibular schwannomas. In any way, this is one of our last papers regarding this concept of peripheral nerve tumors in pediatric patients. And I want to thank you all. Muchas gracias for your attention.
Well, Professor, thank you very much for make so easy, understandable such a rare and very difficult topic, actually, and in such a few minutes. Thank you very much. And with this lecture, I would like to thank all the speakers for sharing their knowledge and their experience, of course, with us. And
Aziza, do you have any questions?
Some questions, yeah, there are some, I can see there are some questions. So I think that we can proceed with the questions. No, we still have some time.
Yes, yes.
Okay, so the first question is about craniopharyngiomas, and the question is which cases of craniopharyngiomas would you do endoscopically, and the usage of transcallosal interhemispheric approach in treatment of in surgical intervention of craniopharyngiomas. I guess one of our first two speakers, either Professor Dirocco or Professor Motolese, could give an answer.
I try to answer. I don't know if Ezio is there. I want to answer this question, but in my experience, I use endoscopic endonasal surgery only for particular case in children with intracellular and intrasupracellular that stay straight on the midline. The other case, I prefer to do transcranial surgery. The main reason is if you look at the complication endoscopic transbasal surgery is the CFS fistula. Then the CFS fistula have different behavior in adult and in children. In children, the problem is when you have fistula, you have meningitis. If you have meningitis, 8% of all meningitis can be fatal for the patient. So we have to have limited to these cases. Concerning the transcallosal approach, in my experience of 40 years, I used the transcallosal approach only in 4 cases. That was a very extended and huge craniopharyngioma arriving until the lateral ventricle. I think that the transcallosal approach is not to be done only for limited special case, because when you go from the transcallosal approach inside the ventricle, you have to understand that sometimes the flow out of the ventricle is pushed very high, is not completely separated by the tumor. When you arrive, you can pass through the fourth ventricle, and you can aggravate what you want. You don't want hypothalamic lesion. So my preference is not this approach that I use in very small cases, but I prefer the subfrontal pteronal approach that in my experience is a good approach for quite all the kind of craniopharyngioma.
Well, thank you very much.
Professor Dirocco, do you like to add something?
No, I agree with Carmine Motolese. I think that the endoscopic approach is still very limited for craniopharyngioma. There are very few series and very few cases that have been published using this technique. And the reason is that in the midline, you can reach very easily from every place. And with the endoscope, if you go inside the cyst, you can see anything because the fluid is not clear. So if you should stay outside, then the microscopic surgery is more safe. So I don't think that endoscope is on the first line. And I think Professor Nasser agrees on this.
I need to add some comment. If once Dr. De Rocco finished with his comment.
I finished.
Yeah. Actually, I concurred with both experienced surgeon on craniopharyngioma. The two limitation additional to be aware of in endoscopic is heavily calcified craniopharyngioma. This is for sure not for transvagal surgery. And of course, the multi-chamber craniopharyngioma is another risk, which becomes, as said by Professor Carmina, that go beyond the midline. Management of complication, this is the issue in craniopharyngioma. If you pull on this cyst wall and you rupture one of the vessels, you are in catastrophe, where you can handle it much better by the terional approach. These are the 3 points I want to add. Thank you.
Very large. All right.
Thank you. Thank you very much. Now, regarding the next question, actually, I don't think it's a question, it's a comment. And I think that we all know that according to the 5th edition of the CNS tumor classification, mixed papillary ependymomas are classified as grade 2. So there is no doubt about it. And let me check whether there, I guess we are done with the questions, actually. I cannot see any other question. Can you, Professor El-Ghandour, is there any other question that I missed? Or Professor Kanan? I don't see any other questions. I don't know whether any one of the participants or the speakers have to do any comment or...
Yes, can I do a comment
yes,
on the presentation of Professor Solansky? Is very important for me. It is very interesting. Because I think that the problem of brainstem biopsy is related mainly to understand and to know very well the biology of this tumor. This justifies also in France the opportunity to do biopsy. But there is some problem because all the studies that we have done have not yet published the real experience of this study. And this is for us that we have a patient is a little bit complicated because practically I think that it's important to know well this tumor. All the progress will be through the genetic understanding of this tumor. But until now, and I do biopsy for a long time. And I remember when in the 19 years I'd done a biopsy of a brainstem tumor, all people criticized me. Now is a necessity. But from a practical point of view, I have not yet seen important progress with the new protocol that we have been doing for this tumor. So, what is your true feeling about this problem, Girish? Because, as you said, it's important that the family are not against the disease. What your feeling as a doctor, the surgeon? What is the gain for you in your clinical experience? For me, the gain is very small, and we are obliged now to publish all our experience in multicentric study, but we don't know what happens in different centers. In my center, the gain with this DPG tumor is very poor. So until my question, until when we have to succumb to this answer to us of our oncologist?
Thank you, Carmine. I think I completely agree with all the points you've raised. the issue of the biopsy is often correlated with does it make a difference outcome? And that is, of course, very difficult to answer. All the clinical trials that have started, they will take 2, 3, 4, 5 years before we actually know what's happening with these children. But let me put it in two different ways. One is, should we do the biopsy or not? And I think for that, because the biopsy under specific conditions of accuracy, image guidance, it is reasonably safe, then I would say if you have an atypical brainstem tumor, we tend to offer a biopsy. If it is a DIPG, then it's a little bit more controversial and is often dependent on the parents. So some parents don't want any treatment. They don't want a biopsy. They just want to go into palliative care. So they may undergo radiotherapy because it might buy them a few weeks. It's a very emotional decision, and I completely respect that there may be different views on this, and there's no science here at this point in time. There's a lot of decisions that are made in conjunction with the families, and sometimes your own heart will tell you what is right and wrong. So that's the way I would answer this, because that's what I do in my practice. Then the issue of gain, I think there's a lot of promise that high-grade gliomas, which were uniformly fatal, particularly in the pons, but of course diffuse midline glioma now is known to affect the whole of the midline, high-grade thalamic tumors, in hemispheric tumors. So the biological therapies that are being developed may come to show success as well in the pontine region. I'm not sure that we have been able to prove that so far. And I don't know whether we will, because some tumors are incurable, despite knowing the pathology and knowing the mechanism of the embryonal pathways and all of that. So I think that's, it may not be immediate, whether we're going to find a correlation between doing a biopsy and having success in the biopsies. But I think more and more we're going to be mandated to do these biopsies, because the oncologists hold the clinical trials and they demand biopsy now to enroll patients in clinical trials. And of course, this could be a problem. And I'm open to hearing the views of, my mentors. And I see Ezio is here, and I would very much love to hear what are your thoughts as well, Ezio.
Yes, but this is the true problem. We have to ask something that until now, from years that we've done this study everywhere, that does not improve clearly the survival of patient, but also we have to say to parents, these are also our difficulty, we can see the problem completely different. Your baby have 1 year to live. We want to work with him for 1 year without doing nothing. Or if you want, we can give a tailored protocol. But we have to do a biopsy. This is for parents, it's not very so easy to choose. And this is a very strong problem also for us, because if you don't do biopsy, if your oncologist say we cannot choose a very good treatment. No, this is the problem, and so it's very important. So the other problem, we don't know at what time this different protocol stop to have a real evaluation. This is in the case of biomed. If you want to also present your own experience of clinician, you cannot do this because you cannot report what is your real experience with the biopsy, with the patient that entered or not in tailored protocol. It is very, 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 very important that we are now, I think, submit this voluntary. This is our, not our own voluntary, but that of our oncologists.
come in. I think this is a very extensive discussion on the the outcomes. But I think for me is how safe is the biopsy, and can we perform the biopsy safely? And the immediate data from that is very good. When we do a biopsy, the patient can go home in a few.
Girish, the biopsy you have shown what we do this, the incidence rate of a very good center of a complication for biopsy, if you are honest, is between 2 or 5%. And if you have complication, you have aggravation of facial nerve of hemiparesis. So this is not nothing for me.
And nobody's saying it's nothing. We have described a number of papers that describe exactly that percentage you said, 2 to 5% permanent deficits and 5 to 15% temporary. But that is the risk of a biopsy. But there's no mortality in 10 years now, at least on the reported papers.
I agree there is not mortality, but I agree that it is not zero complication. This is a point. And for me, 2% or 5% for this patient is too much.
I mean, there is no operation that we do where there is 0% complication.
Yes, but you can also at that moment we can establish if you have a gain or not.
Actually, I think that you are both right, and this is a very extended and a huge discussion, and we can talk about for hours. If we had the time, we could so. And I think that you are both right, and the truth is somewhere in the middle in such a very sensitive topic. And as I can see here in the question and answers panel, there is another question regarding, I don't know, Professor El-Ghandour or Professor Cannon maybe can give an answer. The question is if there is a YouTube channel where somebody could access the recording lectures and discussions.
Yes. Anesthesia, this webinar is recorded and it's going to be over our YouTube channel.
Okay.
Just tomorrow.
Okay, great. So this is for our colleague. Yes.
Can I ask a question to Professor Sokolovsky?
Sure.
I'm not sure to have understood well. It seems to me that he says that in case of a malignant tumors, he prefers to wait until symptoms appears. And I would like to know if means that we have to operate only when there are some problem, or a early surgery could prevent some worsening or delay at least the worsening, as in case of neurofibromatosis 1.
Is Professor Sokolovsky is still with us? Maybe
seems not.
Yeah.
Okay.
Maybe he's not. And there is one colleague asking for Professor Solanki email just to keep a contact with him. I guess that I don't know if Professor Solanki would like to provide his email to this colleague.
That's fine. I haven't seen it, but is that somewhere on the is an open question? Is it? Of course. Yes, I will send it.
Okay.
Last question to Professor Solanki. When you say the family agrees, what do you say to the family? What is the goal of you do? You clearly tell them that the child will not have any advantage, or just you let some things for the family to believe that some things good could happen. Because ethically, would it be very difficult for me to tell to a child, to a family of a child, we do an operation, no mortality, few complications, but completely useless for your child. Maybe for the other children one day, we hope. But in this single case, how you do approach the family?
Yeah, so what we do, as you are absolutely right, and I've gone through all of those personal concerns of mine, which, I share with you, it's primum non nocere, why do something for which there's no benefit? There's all this, concerns. So normally the way we break bad news or we discuss about these things, we have a oncology, neurosurgery, and a supportive nurse. We make sure that the family also has a supporting companion or family. We encourage them to even discuss with their religious leaders to take advice, because this is such an important decision, which must not be left to people making biased, offerings. So I usually ask them, look, we need to talk about this, but by all means, don't feel compelled to make a decision right now. And we encourage them to talk to family, talk to religious leaders and people that they consider important in their life, to seek guidance and advice. And the issue, of course, we know that the survival of this child is limited, and no matter whether the biopsy is done or not, the only possibility here of that the outcome might change is if the biopsy shows that it's not a DIPG. But if and there's about 20% chance that that might happen in some of the reported series, particularly in the atypical appearing MRI scans. But let's say that we're talking absolutely about one that we think is a classical DIPGs. And in those cases, it's very difficult. And I always say, I'm here as a member of your team, mom and dad. I'm here to do what you wish me to do. I'm not here to tell you what you should do and shouldn't do. I give no compulsion at all, and I seek to hear from their heart what they want to do about their child. And most of the times, if they say, no, we don't want anything, and that's the end of the conversation. Never impress that it could save somebody else, or that's not that's very selfish. Nothing like that. It is their most precious possession, and I always start the conversation by telling them that I feel privileged that they have trusted me with their most precious possession, their child. So it's my responsibility to rise to that trust, and for me to be there to do whatever endeavor they want me to do. And if they say, no, we don't want it, and that then for me is the end of the conversation. But I give them all the information I have about the possibility that despite being very sure what it is, there is a small possibility, somewhere between 10 to 20%, that it may not be what we think it is. That's one. The other one I tell them is that in previous studies, doctors have found unusual things from these biopsies. Then that if, for example, a diagnosis is less severe, then the result from treatment may be different. And a lot of this conversation is then done by the oncologists because they are the experts on treatments. But for me, the important thing is to tell them sincerely what I think the results of the biopsy will be. And we also give the results of our series, local series of these biopsies. And, I can tell you we've had at least one patient that had a weakness of a facial weakness that developed, but recovered completely. And so there are some patients who may have transient complications. We fortunately not had anything more severe than that. But I try to be as honest as I can. And I tell them from the beginning, I'm here to do what you would like me to do. Never the opposite. That's the way I feel.
But if you say that 20% the probability that to find some things different from what you think is influencing the family.
Well, I give them a range because I think that the diagnosis of the IPG varies so much between the centers radiologically. It's incredible. And sometimes even two radiologists can't agree whether it's the IPG or not if you ask another center. So I am always concerned about that as well. There's no central diagnosis of the IPG in the country. So different units have also different how do I put it, accuracy on radiological diagnosis. I don't know how it is in Italy, but...
No, I think that it's very ethical because if you say that different centers make different diagnosis on the same tumor, implies that your center can make mistake in diagnosis. This pushes the family to try, not hope, but maybe the diagnosis is wrong because the radiologist can have a different opinion. Then I will 1,000 probability, 1 million, the family will be influenced. So, but I'm not criticizing. I'm just it's a very difficult to be objective with the family.
Absolutely.
Even the way in which you say the words can influence it.
But I've described the way I do it. I don't say that everybody does it that way. And also the 10 to 20% is not from our hospital. It's what is published series. So there are some series that report up to 20% of different diagnoses to what was the provisional diagnosis. But I absolutely, read what you're saying, and I'm supportive of that. I've not made up my mind personally about these things, but the situation, as Carmen was saying, is that we're being led in the direction of having to do these biopsies because all of the clinical trials now will demand it.
What about a liquid diagnosis will come in the future? I'm more expert.
Of course, I might also echo what Concesio is saying. These families, they are desperate. And we should not push the decision-making on them. We should not let them make a decision of management of a medical issue they are not aware of it. And this is a tough situation. And the way I feel, how I handle this one, do I subject my kid, if they have this problem, to a biopsy? Will you do that, Dr. Girish? This is how the best decision you make when you take one of your very close family member and you have to make a decision for them. And this is where the situation. Science is something, I agree with you, but again, this is, I don't want to say unethical, but this is an ethical issue. Even we are given a hint that there will be a potential, and we put them in that situation. This is a major decision for them. They said, well, we are not the doctors to make that decision. And I agree with them. And I feel this is, and they are desperate. They want to have something, but the value of it should not be inflated. I doubt that you are inflating the value, but you give them the option, either a slim and grim option, but it's a grim option. This is what I feel. But I have to echo as well for Anastasia. She said, both are right, because no, we cannot take, he is wrong, he is right. So I think we can discuss for the rest of the night, and we won't be in one way or other biased to our own decision making. I think Nasser, you might.
Maybe Ahmed, I think Ramiz Zakarullah is typing a question. Ramiz, do you like to ask or to comment?
It's a different topic than that. I asked the question a few times. I never got an answer. For residual or recurrent craniopharyngiomas, the site of the residual is mostly infiltrating the hypothalamus, and let alone that gamma knife, you require a gap between the optic chiasma, but giving a high dose with gamma knife for a residual infiltrating the hypothalamus, does anyone knows causes more dysfunction rather than fractionated radiotherapy in the long term?
Yes.
We ourselves use diffractionated. Even, I mean, we don't have gamma knife, we have cyper knife, but we'll go focal radiation, but fractionated. And the tolerance of the optic apparatus is much better, and the hypothalamus much better.
Yeah, that's what we wanted to do before, but I can see a lot of reports about gamma knife. I just want to ask the experience of people who do that on the long term.
A fractionator for me is safer than a single dose. Because it's very, very sensible, the optic pathways to the radiation. So even if accurate, they still can be involved. And
Proton therapy, yes. Proton therapy.
Maybe one day, maybe. So I could add. No, what is interesting, when you do operation for a tumor of the optic pathways, and you see infiltration on the hypothalamus, but it's unilateral, you can remove this tumor, damaging the hypothalamus. The child will be in very bad condition for 10 days, then will recuperate. So it seems that half hypothalamus can still be sufficient, but obviously are different tumors. I don't know if it works for craniopharyngioma. I never see craniopharyngioma that infiltrate only one part of the hypothalamus, like the optic pathways tumor can do.
Okay.
Thank you.
And with this, I think that we've done, and we are at the end of this webinar.
Thank you, Anastasia, for excellent moderation of this session.
Thank you for
I'd like
having
to
me.
thank all our distinguished speakers and moderators. Thanks to organizing team. And it was excellent webinar extending for 5.5 hours. Actually, I enjoyed the discussion. I don't like to close the webinar, but we have to do so. I give the mic back to my friend Ahmad Kanaan to say his closing remarks and close the webinar.
Well, I'd like to thank all the moderators and the speakers being honest and sharing their experience. I learned a lot from that discussions, and I hope you have a great events and a nice evening to spend with your family. God bless you all. Thanks, Dr. El-Ghandour.
Thank you. Thank you very much.
Thank you very much.
Bye. Thank you.
Bye-bye.
Thank you.
Bye-bye.
Thank you very much.
Bye-bye.
Bye-bye.